Bore da chi gyd, a croeso i'r bwrdd iechyd Brifysgol Narba. Good morning, everybody, and it's very nice to see so many of you in person after all this time. We've got today's meeting will be recorded and published on our website as usual following the conclusion of the meeting. I've got a lot of pleasant tasks to do in terms of welcoming new people, particularly Jennifer as our new Director of Nursing, and Chris Dawson Morris as the Interim Director of Planning, a very long title. What else are you in charge of plan performance? So we've got all the jobs. And particularly to Nicola as our new Chief Executive and first meeting. So welcome and hope you have a long and successful time as Chief Executive. I look forward to working with you. We will be joined by a number of guests. We have Gemma, the Chief Officer of the Council. Sam Brooks will be joining us, the Relationship Manager from Health Inspectorate Wales, who is going to support agenda item 4.2, the HIW annual report. And we are going to be joined by a number of staff. Victoria Taylor, Head of Primary Care, Sandra Mason, the Assistant Director of Primary Community Care and Mental Health Services, who is standing in for Chris O'Connor today. Kevin Arundel, the Finance Business Partner. Linda Alexander's coming, our Deputy Director of Nursing, and Claire Lippitz and Jane Beasley, Head of Midwifery and a Divisional Director of Families and Therapies. They'll be joining us for the relevant agenda items. We have apologies for absence, just from Chris O'Connor. Are there any declarations of interest that we need to note? Yes, please.
It's only a potential interest, and that is item 3.6, fees.
Right, lovely. Thank you very much.
Currently contracted, but
yeah. Thanks, Tish. Thank you. Can we move then to the draft minutes of the Health Board meeting held on the 27th of July? Are there any amendments? Is it a true and correct record? Yes. Okay, so we adopt those. The summary of the board business held in committee. This is an overview provided for noting. Are we happy to accept that? Yep. And if we can move to the board action log. Can you take us through, please, Ron?
Thanks, Chair. So there's 5 actions included on the action log, all of which have updates in the potential and progress column, most of which are complete or have a final date for where they are scheduled.
Any questions, queries? Do you think we've missed anything? No? That's okay. Thank you. We move to 1.7, report on sealed documents and chairs actions at Rami.
Yeah, so this paper provides the board with a summary of the use of today's action and the Health Board's common seal between the 12th of July and the 13th of September. During that time, there have been 6 documents that have required the use of the Health Board seal, and they are the detail of which is set out in the paper. And in addition, there's been 7 chairs actions taken, the detail of which is appended to the report. The board is therefore asked to ratify the use of the common seal and the use of chairs action in the standing orders.
You have to accept that and adopt it and agree. Okay, thank you. 1.8 report from the chair, very brief. Apart from my normal suite of meetings and bilaterals, I've had meetings, some of which have included the Chief Executive with HIW, our usual catch-up meeting that was positive and supportive as ever. We had a very, very long chairs meeting yesterday, at which we discussed, as you would expect, urgent and emergency care and what everybody is doing about urgent and emergency care, because everybody seems to be reporting the same difficulties. The progress that we're making on planned care recovery, which again, there is a similar theme running through all the health boards. We discussed accelerated cluster development, some concerns about the governance, and I'm pleased that Rani, on behalf of the board secretaries, has been taking forward a paper on the governance of accelerated clusters, how they relate to regional partnership boards, how they relate to health boards. It's still not clear, despite Rani's best efforts to try and clarify this, but it is something that certainly we will be returning to at our next meeting when there is more clarification and more guidance available, because we will have to think through very carefully the implications for the health board and for the RPB, given the scope that seems to be emerging to be carried by these accelerated clusters and the planning groups that go with them. It's quite a serious problem. We had a very long discussion about the current financial situation throughout Wales, and there is an agreement that the chairs and the chief executives will compose a letter on the pressures, not just financial, but in terms of activity and emergency care, to the minister to explain our collective position, to make sure that she is assured that the circumstances are being managed, but that we are very clear about what we can do and what we will all sign up to achieving. So we have decided that that's what we shall do. There was we had an update on the NHS executive, which is supposed to be coming into being on the 1st of January. They are going through, the Welsh Government is going through an analysis of the roles and responsibilities of that executive. They're doing a paper on functions, which I will circulate to you once I have received it. There is a discussion about the mandate. Now, there is a meeting on NHS executive this afternoon. We have not yet seen the work on the mandate, and quite frankly, I don't know how you can construct something unless you know what the mandate is. So, you know, there are some concerns being enunciated by chairs and chief executives about that. But I shall send you a note once I've had a report back from today's meeting on how it is progressing, but progressing it is. And finally, we had a debate with Welsh Government representatives on their programme for aspiring board members and the anti-racist plan. And I will again circulate a note when I've had their report in writing, so that we all know what their ideas are and so we can discuss what our ideas might be for aspiring board membership. They are thinking of running cohorts of recruitment to independent members. We were not exactly enthused by that idea, because health boards' needs and requirements will differ, and we need to make sure that people quite understand the organisation which they're aspiring to work. So we will watch that as well. I've chaired a meeting of the Regional Partnership Board, and I will return to that later on the agenda. I attended a Care Action Committee meeting. The Minister has reformed the Care Action Committee. This is to look at the interface between health and social care and how we can bolster social care to enable it to fulfil its obligations, which includes obviously staffing and different structures for staffing and the way in which care can be delivered. And I will circulate the notes of the meeting when I receive them. I met with one of the new leaders, Mary Ann Brocklehurst, this week in a very interesting conversation. She has some very interesting ideas about social purchasing, and we have commissioned some work from her chief executive so that she can present that at the Public Services Board. And she really has got some very interesting ideas which will be very helpful to the community. We had a meeting with the Minister last week as chairs. Minister's obviously very concerned. You will all have heard about planned care, recovery and the emergency situation. And she reiterated her concern on that, but thanked everybody within the health bodies for all the hard work that they're achieving. And she fully appreciates the pressures under which our staff continue to exist. But it was a very sober meeting. And I finally now had my objectives for this year, which I will circulate to you, and I have handed most of them to my able chief executive to complete. And, yeah. Any questions? They're worth reading. So, anyway, okay, thank you. The report from the chief executive.
Yeah, thanks, Chair. And I thought it was an important opportunity to just kind of share some of my initial thinking as I moved to the role. And I firstly wanted to just take the opportunity to thank everybody for the huge amount of best wishes and support I've had in starting in the role. It really has been humbling, and it's made the whole transition much easier for me personally. You know, despite being week 4 in the role, I've had the opportunity to get out and about across the organisation, meeting different teams and individuals, which has been really, really refreshing and really positive actually, because despite the difficult 2 years I think we've all been through, and our staff in particular, there's still a huge amount of energy here, and we are forward thinking by the team. So we really want to kind of take stock of where we are now and really start looking at new ways of working and building on the learning of the last 2 years. So being able to use that and build that is going to be a real key priority. So hopefully I've hit the ground running. I obviously know the scale of the agenda and very familiar with the organisation. So it's been quite nice now having to kind of start from scratch. So very aware of the challenges that we've got ahead of us, and spent quite a bit of time with the executive team, really framing what I think are some of the most immediate priority areas, the immediate risks that I need to focus on with my colleagues in the executive team and for us as a board. So the 4 biggest, most significant risks that we're particularly focusing on, which I thought was just useful to set out. One of those is our preparedness for the winter. You know, I think we're all concerned about what winter's holding for us, not just for us as a health board, but what we need to do as part of that wider system right across secondary care, primary care, and working with social care as the chair's just referenced. And there's a number of items on the board agenda today around the RPB and the winter plan that kind of sets out how we can do some of that. The second area that's probably a key concern is around making sure, whilst we're trying to work our way through some of these challenges, is managing patient safety and risk appropriately across the whole system. Huge, we could put in an enhanced focus by the executive team on the ambulance issues, the front DD rates, which we know attracts a huge amount of attention, and also kind of part of that is about how we have a wider clinical discussion about how we manage our risk appropriately across the system, recognising this balance. The third area is around cancer performance, and we've talked about it various times in the board, and we are concerned as the executive team around cancer performance and addressing that growing backlog in the context of the challenges and demand, increase in demand. And we pick again some of that up through the performance report today and the pathology proposal that we've got, a huge focus on there. And the fourth one is finance, significant financial challenges that again, as the chair referenced. You know, we very much we've seen a reduction in COVID funding we've benefited from non-recurrently over the last 2 years, at the same time when our costs are increasing, and how we try to balance that is going to be a huge focus. And again, the executive team spent a significant amount of time in the last few weeks trying to get our head around this, and again, a number of items on the agenda for us. So wrapped around those 4 kind of significant risks, and 2 real themes is one is workforce. If we don't look after them, as we try to resolve these issues, then we really haven't got any chance. And our recruitment and retention needs to be taken to a whole different level, I think. And I think some of the insight and the feedback and listening to what our staff are saying, we've got to do something different. And the second one is patient experience and public communication. I think a lot of the feedback we get from the public is not often about the clinical care, it's often about the experience while they're waiting, not sure what's happening, can't get through to the right person. And as an executive team, we really are looking at how can we offer something different and support the public and patients in a different way to what we've done before, because we are very much in a different situation. So they are kind of the 6 key areas, and the executive team's been looking at our ways of working. I think we as effective as possible, use our time effective, be more visible, be connected to the organisation, and work more effectively as a wider board with our independent member colleagues. And a key theme again that's coming up that we really want to try to change is around empowerment and accountability. If you listen to some of our staff surveys and what the organisation is telling us, we need to work differently, I think, around how we empower staff to feel we can make some of those changes. In obviously some of our controls and procedures, but really trying to think differently. So that's just a brief overview I wanted to share around where our focus is in terms of the immediate issues. Recognising there's a huge agenda and lots to do, but it was important to really focus on those key risks and those kind of key opportunities that I want to move at pace with and not spend too long. So hopefully, it's speakful, but I've really enjoyed the role. Generally feel hugely motivated despite all the challenges and really privileged to have the opportunity to lead the organisation to hopefully a more sustainable and positive future. So I hope that's helpful. The plan is that I'll do a more formal written chief executive report in future meetings that will complement a refreshed executive team report that Barney and I are working on. Hopefully that'll be helpful in terms of future board meetings. So thank you all again, and forward to continuing in the role for many years. Yes, yes, we don't have to go through it all over again. But thanks ever so much for that. Are there any questions to Nicola? No. Well, I think they're the right priorities. They're the ones that I think the board will definitely endorse. We are here to help you and this organisation succeed. So we're right behind you and the team, what you're trying to achieve. Thank you very much for that. Thank you. Shall we move to section 2, patient experience and public engagement, and the report from the Aneurin Bevan Community Health Council, Gemma. Good morning.
Morning, Chair. Thank you. Morning, everybody. I think the new chief exec has pretty well reflected the concerns and the priorities that the CHC would also endorse taking forward. I know that board will have read the CHC's full report, but just to give a highlight of our current concerns, which are ongoing from previous reports. We're continuing to see high numbers of people waiting outside the ED, either in excess of 3 or 4 hours on the backs of ambulances waiting to be handed over, and how uncomfortable and sometimes undignified that can be for people in the stories that we hear about those. We're also seeing throughout these months an increase in number of delayed transfers and discharges from hospital, and ahead of winter. The CHC is concerned about the system's, ability to cope over the winter period, knowing that we have, some of the highest levels of delayed transfers of care this year. So it would be really useful for the CHC, and I know that the Health Board is planning to bring its winter plan to our joint executive committee meeting tomorrow. So I know the CHC will be eager to hear more about the winter plans and the reassurance that we're looking for in that respect. It is important to reflect that patient experiences are poor, and that's not to say that the clinical care or that the staff aren't working as hard as possible. We do hear really positive feedback from people about the clinical care that they receive once they have waited a long time, but we mustn't forget that the experiences are very difficult for people whilst they're waiting to enter the system. And the CHC does recognise that the response to this whole system pressure isn't just health's responsibility, and this stretches far wider into policies, decision making at Welsh Government level, but also into social care, with social care and domiciliary care providers as well not being available to take people when they are ready to go home. But on that, the CHC has formally then written to the new chief exec and to the chief executive of the Welsh Ambulance Service ahead of winter to seek some formal assurances for the patient's experience and what the patients can expect ahead of winter time. So on whole system pressures, I do recognise that this isn't just an Aneurin Bevan's issue. This is whole system across the country. And the CHC has escalated its concerns to the people within its remit at the moment, and I know the Citizens' Voice body for health and social care next year will be able to take a closer role in scrutiny within social care services too. But our concerns do remain around that. Just to highlight one other thing from our report, board members will know and have been keen to know the outcome of our cancelled operations survey. It's interesting to note that of the 2,500 people we surveyed, we did get a good response rate of 10%. About 200 people replied. Largely, people told us they did not cancel their procedure, but the health board did, or the hospital did, or there was another reason for the cancellation. So I thought it was really key to highlight that discrepancy there for your attention. But on that point, Chair, I will pause and ask the board if there are any questions on the whole CHC report, please.
Thank you very much, Gemma, and thank you to the CHC for the diligence that you apply to seeking out the views of patients and their relatives, which are really, really important to us. And I hope you've seen that we do act on your recommendations and on your findings. Are there any questions to Gemma? Bevan?
Yeah, I just have one, and it's really just around a bit more clarity of the numbers of people who've had cancelled operations. And I mean, I thought it was really interesting to read, but I couldn't get a grip on the numbers from the report, or what percentage we're talking about that we as a health board can do something about, because that makes a difference to patients at the end of the day. So if we had an understanding of what percentage falls into what category for the hospital, then maybe that gives us an opportunity to improve in that area. But I just wondered if you had those figures.
Yeah, so we had 50% of people tell us that they didn't cancel their procedure. We have broken that down by division. Our full report then does highlight the total number of figures within each division and the primary reason that somebody cancelled for that division. So in our full report, which was submitted to the Health Board a few weeks ago, and which is on our website, you can see very clearly the figures, the percentages, and even the differences in why people have cancelled for different procedures. So if somebody had a longer recovery period, say in trauma and orthopedics, they were more likely to cancel because of home commitments or work commitments, because they would have a longer recovery period. If they were having a day case and the recovery period was a little bit shorter, they might have only cancelled on the day because they couldn't get transport. So there were a number of different reasons per division, and we've broken those down very succinctly for you.
That's right. I mean, it's really helpful because that gives us an opportunity to improve, doesn't it? So.
Nicola and Leanne?
Yeah, thanks, Gemma, and thanks for the report. It's really helpful. I think just following on the cancelled operations, and we will obviously be doing the work around reviewing your report, but we will particularly follow up where there's a different view about who's cancelled the operation, just again to get some assurance that our system of ensuring that information is correct, because that's also a concern if there's a different interpretation of who's cancelled. So we'll absolutely follow that and reassure the board that
Thank you. Leanne, just to provide some further assurance, we were requested to respond in particular on the cancelled operations back to the CHC at the end of last week. A very detailed, comprehensive action plan has been created. A simplified version has gone to Gemma rather than get into the lots of details, but with a heavy focus on both what we can do organisationally, split by specialty, but also sort of how we interact better with our patients around the communication piece. Good. So there is a very detailed piece of work that sits behind it. Happy to circulate that or just sort of share some high level detail with people, just to give that assurance that there is a focus on that. Because I think with the backlogs that we currently have and the patient experience in terms of their weights and safety issues with the length of wait, the teams are very well aware of the importance of maximising the capacity that we have available. There have been some, just being very open about it, challenges for us in terms of some of our staffing and some of our admin teams. And I think it's important, I think I've probably shared with the board previously that posts that we've historically been very easily able to fill is much more challenging now administratively. And I'll cite the example of our booking centre being a
about half our establishment. Nicola's already referenced the importance of right-sizing our workforce. So I think there's a multi-pronged approach that we need to take, but there's a detailed action plan to respond to those issues and concerns.
Thank you, Leanne. I think it'd be helpful if you could circulate to do simplified version. Good. Anything further? Anything further? Paul?
Just to say, I think agree, very useful and informative, Gemma. Out of interest, is there any comparison with other CHCs in Wales in terms of sort of some of the issues that you were raising compared to across the rest of Wales? Or are any particular issues with outliers on?
I can't confirm whether you're an outlier at the moment, and I certainly know that the CHCs in other areas haven't completed a similar exercise like this, but I have shared our way of undertaking this activity, and this for other CHCs then to take forward, you know, a similar approach in their area. But certainly in AB, we were the first ones to undertake this sort of review.
Thank you. And actually, this is it's not a question or a comment for the CHC, but something that arose from your report, which I always find really great because we need to think about, you know, the people that we're serving at the end of the day. But it was just around the visit that happened to D3 East and the fact that the disabled toilet was out of order. And I think the sentence that struck me was that it had been for some months. And so for me, there's a question about how do we escalate things like that? So the people who are on the ward every day will know that that is out of order. So how can we ensure there's a system to make sure all of that is followed up so that we don't have services that people can't access? So it's more of a facilities thing, but I was really pleased to see that it had been highlighted.
Thank you. Any further comments? I'm grateful for your analysis of the consequences of emergency pressures, and I think that we must, as part of our recovery of emergency care, look further at how we manage people waiting in a community in a better, more appropriate way. We're obviously talking about diversion schemes at the front door to ensure people get to the right place quickly. And I know that Leanne is working with the Flow Centre to ensure that people get to the right place in a more effective way than just using the 111 system. So hopefully we'll be able to keep you up to date on areas where we are improving, because it's really important. It's the most stressful period of time for individuals, and you just don't want to be held up or think that an ambulance isn't going to come in a sufficiently good time. So we'll be taking that forward. So thank you very much, Gemma, and we look forward.
Thank you, Chair.
To meeting tomorrow.
Thank you.
Thank you.
Chair, sorry, yes, a quick question. So this isn't a question for Gemma, it's a question for us. So the post-COVID syndrome survey, clearly Gemma and team are circulating that. Are we circulating that ourselves to the community? Are we highlighting it? And Gemma, how are you getting that out to other stakeholders in the community that might have you know, that reach that we need?
Yeah, we've worked quite closely with the long COVID or post COVID team locally. So Karen Gully and her colleague were quite closely involved in helping us put this together to make sure that we were asking the right questions to start with, and have helpfully will be distributing this hopefully to service users. But you know, in terms of our networking, the Health Board's comms and engagement team is always really helpful in circulating our surveys and has done so. But I've seen this survey particularly in other bodies' newsletters, such as the Gwent, GAVO with Gwent Association of Voluntary Alliances and the TVA. But we directly send everything to local authorities, for the town councillors. We try as much as we can through our own network distribution list to highlight these. And also we've been fortunate enough in AB to get back to some face-to-face engagement work as well. So we've been to a number of fairs and engagement events such as the Usk Show, Pontypool in the Park. We went to Cardiff Mellor last week, So we're circulating our local surveys as widely as we can, but internally with Aneurin Bevan Health Board, your teams are supporting that too.
Thank you, team.
Sure.
Yep.
It's comment.
Yeah, certainly.
Thank you, Gemma. Just to say, we really welcome the long COVID survey. It forms a really important part of our evaluation of what is a brand new service for the health sector, and we'll be keen to incorporate the findings in our overall evaluation as we now take stock of that programme of work and look at that in terms of what the future holds in terms of that service. So this has been a really important part of that evaluation. So just to say thank you for that, and we'll certainly be looking at that with great interest.
Thank you, Peter. Thank you very much, Gemma. And we look forward to receiving your next report and reporting on action that we've taken as a consequence. Can we move to items for decision? The first one, primary care sustainability, and Victoria Taylor is going to present this. Welcome.
Thank you, Chair. So I'll just take you through the first report, which is the Blaenavon Medical Practice Report. So the purpose of the report is to inform the board of the outcome of the vacant practice panel for Blaenavon Medical Practice. On the 16th of May, the Health Board was notified that by the partners of their intention to resign the GMS contract with effect from the 31st of December. At this time, the contract was held by 4 GP partners. However, 2 of the GP partners resigned from the partnership in succession, and this then prompted the resignation of the contract, notifying the Health Board on the 16th of May of their intention to do so. As a result of this, the vacant practice process was implemented. Blaenavon Medical Practice is located in Blaenavon Resource Centre. The practice has a list size of just over 6,500 patients, and their practice boundary covers the council wards of Blaenavon, Abersychan and Llanwenneth Ultra. A vacant practice panel convened on the 25th of May, and the panel included representation from Gwent Local Medical Committee and Aneurin Bevan Community Health Council to consider the options available as part of the GMS vacant practice policy and to determine the most appropriate course of action for the future of the practice. Option 6, as part of the policy, was not applicable in this instance. However, options 1 to 5 were discussed and considered fully. The panel agreed on recommendation of option 1 and option 2 to run concurrently to advertise the practice locally and nationally with the aim to secure an alternative GMS provider for the contract on a full list basis, and this was subsequently approved by the executive team. The practice was advertised with a closing date of the 4th of July. Unfortunately, the Health Board did not receive any applications. As a result of this, the vacant practice panel reconvened on the 3rd of August to consider the remaining options that were available. Options 3 and 5, and this is where a managed list dispersal or a dispersal of the practice list is considered. Many factors were considered by the panel, including the geographical profile of Blaenavon and recognising that 95% of the registered population resided within the Blaenavon ward, and this was not covered by an alternative GMS provider. As a result, the panel determined that this was not an appropriate option in this instance. The only other option for the panel to then consider was option 4, for the practice to become directly managed by the Health Board. Again, the geographical profile of the patients and recognising the impact this could have on other practices within the area, and the fact that we were unable to successfully recruit an alternative provider to secure the full contract replacement, the panel agreed that option 4 was the only viable option to ensure the ongoing GMS care for the patients within the area, and this would result in the practice becoming directly managed by the Health Board. This would ensure that all patients would continue to have access to GMS services and from the existing premises. This recommendation of the vacant practice panel, that we would assume responsibility of the contract and directly manage the practice with effect from the 1st of January, was subsequently approved by the executive team. There have been a number of actions taken since this decision and approval. The practice has obviously been notified and stakeholders have been informed of the outcome. Patient letters have been issued and they should be received this week. And we have meetings now with the practice team. These meetings have commenced and will continue to ensure a smooth transition from the 1st of January. The existing GPs have expressed an interest in remaining to work within the practice, and all salaried staff will be eligible for 2P where their employment will transfer to the Health Board from the 1st of January.
Okay,
Thank you.
are there any questions? Yes, Paul.
I mean, I think it's a very comprehensive report, Victoria, and I've just looked at the people on the panel. You've got representatives of the patients, you've got representatives of the local doctors' organisation as well, I think the LMC. And I'm just interested in your last part, to say the communications to patients and to staff and potential TP. But I think it's a very comprehensive report. I think they've done a very good job, and I would support the recommendation.
Thank you. Are there any further comments? Yes, Phil?
Yeah, Chair, very much support the report, but I just wondered what happened to the GPs that actually resigned, whether they retire or did they find work within the system? I'm just interested to know what happened to them in terms of a HR kind of overall picture. And the other issue I guess that concerns me is the number of managed practices that probably we starting to take on. And I just wonder whether possibly the quality committee perhaps could look at this whole issue of the practices that we manage. I'd be quite interested to look at whether there's any improvement in quality, for example, of other practices that we directly manage compared to the ones that we don't, or whether it's more difficult, because this is becoming now it's becoming more the norm than not actually these days. And there's lots of practices are getting to the stage where they don't want to be independent. And I just wonder whether this model will be one we will see much more of. But we are kind of having to drift into it. We can't really strategically manage our way into it because we're doing it now because it's the last option. But maybe we would find it could be a first option, but we don't know enough about it.
Thank you, Phil. If somebody could answer the question about where did the GPs go, but on your second point, the managed practice quality comparators, we have a board session in October on managed practices and the consequences, so we can pick that up there. But could you enlighten us, please?
Yeah, so with regards to the 2 GP resignations, I can't confirm whether one GP has found alternative work. My understanding is that they are working within Cardiff, but I'm not sure of that. But with regards to the second resignation, and that GP has already expressed an interest in remaining to work with the managed practice. So we are hoping to be able to retain some of the existing partners, but obviously they would then transfer to be salary GPs.
Thank you. Thank you. Steve?
I had a similar question and around the dynamics, not necessarily of this case, but Victoria work very hard with practices that might highlight that they're struggling a little, or there might be reasons that we might give them some support, and that's excellent. I'm just wondering if there was a lead in with this, and to what extent other practices are, currently putting their hand up and saying that we're having difficulty. The other point was that I'm particularly disappointed with this one because I don't know, Phil, if you remember, you and I went up and visited the resource centre and that practice. And it seems to be the model that we want to be moving to, where we have a range of organisations all in the same place, all able to support people wider than GP services. So it's kind of, the question is about, are more practices in this place and seeking support, and what are we doing to kind of almost get ahead of the game, I suppose, particularly where we've got kind of wider model that we're trying to use.
So yeah, I mean, sustainability of the practices, remains a challenge. You may recall that we have the sustainability framework in place, which is a national tool, and that gives practices the ability to almost assess their sustainability. We do have practices that come forward and identify, and where we can, then the Health Board provides support. There is work ongoing at the moment in relation to this. We've just undertook a workforce analysis, and this is where we are looking at the GP workforce, but also the wider multidisciplinary teams, that's primary care model, to really understand almost like a gap analysis. That information is being shared with practices at an NCN level through a series of workshops. And again, this is the information that we will bring forward then as part of the board development session. We do have some other aspects offered to practices. We've issued the merger incentive scheme, and this provides like almost a financial package of support where practices may look to come together, because we know creating scale sometimes does bring that resilience. So there are various ways in which we are looking at the sustainability, but it is a concern, and this is why we are looking at it, looking at the workshops, looking to bring this information to board, and there's ongoing work at a national level also.
Okay. Thank you. David?
Thanks. I mean, just wanted to highlight again, we've been seeing these cases in pretty much every board meeting for the last little while, and I think back in July we talked a bit about the need to maybe step up the work on sustainability for primary care, and this seems to be affecting particularly Torvine, but not just that area. Just wanted to highlight again that we should make sure we get into this in a bit more detail, because there may be things we could do to try and stop it before it gets to the point of them resigning, and we may be able to do some work there to try and help make this a little bit more sustainable for patients and for the practices.
Thank you, David. Yes, Steve.
Chair, apologies. Can I just come in again? There is a much longer term strategic conversation that we need to be having related to what Phil was saying earlier. And we've been talking about this for a few years, about how GPs, younger GPs, don't necessarily want to come in and take over, going to having, being a partner, managing that practice. They go in to the profession to work with patients, and it's that kind of shift in the expectation of our colleagues. And I think for me, there is a level of frustration about how we're not really responding to that. We have known this for some time, and we need to carve out what our thinking is, not just us as a health board, but in terms of how we deliver healthcare. And absolutely take on point, we need to look on at the patient safety aspects and quality and so on. But this isn't going away, and we need to have those hard conversations now.
Well, that's why it's important that we have this broad session, so we can really tease out what our strategy is going to be. Sarah?
Thank you, Chair. I attended the last NCN Leaves meeting, and it was a major part of the agenda for that meeting. And there are discussions being held between the groups of practices at NCN level ahead of the board development session, in order to actually surface all of those issues around what are the strategic issues. And so I made the point that the board is interested in what are the solutions, and that the point of the board development session was to get into the conversation about what can we do to help. So so there's an active process going on to provide us with the intelligence in that board development session.
Thank you. Thank you. Ewan and Pippa?
Yeah, I think
Richard?
Sarah's just kind of answered part of what I was going to ask. It's around the economics of this. So I'm purely looking at the money side of this at the moment, on what the increasing cost is, or whether there is a difference in cost in us doing it versus practice doing it. And that almost then tells you what we should be investing into it to almost keep it set if it is a cheaper option, kind of thing. So it's part of that, whether there is an economic driver behind how people are pulling out of this as well.
Well, when we first took over some practices, we asked Nick Wood at the time to undertake an analysis of the cost benefits of this. So I think we've got to put that on the table again, see whether or not the the conclusions that he reached at the time are still valid. Because there were certain benefits that did come through quite strongly. And I think it cost us more, but you know, it was the weight of the benefits that
Yeah, which I think
enabled us.
feeds into a bit of what you were talking about. Yeah.
Yes, and listening to most of the NCNs are partners. And as the conversation got going, there's an awful lot of partner time going into running practices that would then need to become salaried time. So I'd be surprised if it's cheaper.
Yeah.
But we need to do the analysis.
Yeah.
But it was obvious there's an awful lot of hours being worked by partners.
Yeah, and I'm just
Because they're
wondering if
partners.
there's that economic driver
Yeah.
behind it all as well.
Well, in the past, the economic model of partnership meant that there was a reward from partnership, but the nature of the model has changed. So I think that financial benefit of being a partner has got narrower. And that was one of the things that they were articulating, that the salaried doctors and what they can earn through a salaried model and what they earn as partners, and that gap has got much narrower.
And if you're a partner, obviously you're taking on a lot of risk yourself, you're not taking on as a salaried individual. So yeah, there's that piece that needs to feed into that analysis you're looking at. And obviously we haven't got the costs of what this particular, there are a number of costs highlighted in this report, but we haven't put a figure behind them.
No, that has to be finished.
Actually, it was something that I was going to mention quite briefly was when we have the board session, it would be really helpful for us to understand what the money is, but what the impact is as well, and the two things combined, because plainly that's what we should be doing. And also I think opportunity, particularly for younger doctors. I was speaking to somebody who's working up in YYF recently. She wants to be a GP, but she's fairly recently qualified and she doesn't want to take on lots of responsibility. So there's a question, isn't there, about whether or not we actively decide that we're going to go down some of the route of managed practices to give greater opportunities to our staff. So I think there are quite a few things there. My specific question really was, what impact does this have on the NCNs? If practices are managed by us, then is there going to be some kind of shift in the governance arrangements around that? Because on the one hand, we're dealing with basically independent organisations, and then on the other, we are directly controlling them. So is there something around that independence, or doesn't it make any difference? And I think that's something else that we should be thinking about.
Thank you. Richard and then Paul.
Fully support the development session. You wouldn't expect me to say anything else given the comments previously. Totally support what David and others have said. This is almost a never-ending story.
Yes.
And I do welcome Victoria's comments that work has been undertaken. Chris promised us 2 board sessions ago after my intervention then that things would happen. So I'm not going to repeat what anybody else said, but there's 2 aspects that I would like to consider in the whole, as well as the recruitment of GPs. I stopped to get a newspaper on the way here today, which happens to be next to the Crosscardiac surgery that's closing. 3 members of the public in 5 minutes, bang, what's happening? I can't afford to go to Trosland, etc., etc. So with the cost of living, some of you may have seen a report this morning on the BBC about cancer patients determining whether they're eating, heating, or going for their treatments, etc. So if people can't afford to swap to, she didn't say mega practices, merged practices, as Victoria said, sorry, Victoria. If people can't afford to go to those because of cost of petrol, cost of bus, cost of taking your kiddies, if you're a parent, etc., are they then going to put off treatment? Are they then going to put off going to see the doctor, which is going to bite us in the backside further down the line when they're going to present to us with more serious conditions than if they've been seen by the GP at the time? I said it last time and I'll say it again. When we're concerned about what's going on at, it's amazing that I forgot the name of it. It's right by me, Grange University Hospital, sorry. When we're concerned about the number of people going there, that people are just going to get it into their head and say, well, I can afford to go there, and I'm going to go there for treatment. And we're just encouraging all the wrong activities. So it's a problem that needs to be solved, and I do welcome the board development.
Thank you, Richard. That's very helpful. Paul?
And I'm just going to follow that up by saying I think the letters have gone out. I think, Victoria, you said so it would be useful to get some patient feedback, patient voice on this particular topic to make sure that we've got that. And I just wanted to just tease out the liabilities issue. You mentioned about people being 2P'd over. Is this a big issue? And perhaps as part of your report, you could include the liabilities part, because obviously we're taking on GP member of staff and we have responsibilities for their sort of being part of our sort of organisation in terms of redundancies and everything else and on costs and what have you. And I just wonder, is that one of the issues, the liabilities?
So there wouldn't necessarily be any redundancies with this because we're taking the contract over in its entirety, the whole business. All those staff will be eligible to 2P transfer, so they will all come over and then still be able to work in their existing roles. We wouldn't be able to deliver the service without those staff. So this is what we have now, is a series of engagement meetings with those staff, and all those that are employed will come over and be part of a health board employed staff.
Yes, so is it cost neutral then in effect or not in terms of the contract or?
So obviously all the funding that's associated with that contract will then be retained by the health board. So the financial model as it is within that is already funded through the GMS budget, and that will then remain with the health board. We have where we have had other practices, there is a cost pressure if we are unable to secure salary GPs, and then we are reliant on locums, and this has happened in the past in the managed practices, and this is why we'll now continue to work with the staff and the team, and certainly the GPs, so that we hope to be able to secure their workforce as well from the 1st of January.
It's quite useful to put all this together in that room.
Yes.
Yeah, well done. Thank you, Victoria.
Thank you.
Thank you.
Yeah, thanks, Chair. Thanks, Victoria. So it just builds on how we use the development session, and one of the areas I'm quite keen, which I think Frankie can understand, but we don't as a board, is that kind of state of the nation of where we're at. Which of those practices and areas that are very sustainable, we're not worried about, they've got, a big catchment, plenty, versus those we know are vulnerable, so we can start being more proactive in terms of which are the ones we think are the highest risk of either closing branch surgeries or becoming a vacant practice, so that we can start almost more strategically looking about how we can address some of those issues. So I'd like us to try and make that a little bit more transparent for the board in the board development section.
That's helpful. Thank you. Thank you, Victoria. So we note the recommendation of the management of this vacant practice. Passing on to the Ebbw Vale Dental Services. This is a ratification of the Chiefs of Chair's action. And then this is a much better news story.
It is. I will quickly just take you through the report. You said, Chair, this is to ratify Chair's action following the tender process and outcome to secure NHS dental services in the Ebbw Vale area. So just some background on this. On the 12th of May, Bethcard Dental Practice informed the Health Board of their intention to terminate the existing National Health Service General Dental Services contract with effect from the 31st of August. As a result of this, the Health Board entered into a tendering process on the 10th of June, and this was to secure ongoing NHS dental services with provision for the existing 8,255 patients that would be affected by the contract termination. The tender provided an opportunity for existing NHS dental providers to increase capacity or to establish a new dental practice, and this was advertised both locally and nationally with a closing date of the 27th of June. The Health Board sought interest from practices to tender on a full or partial basis with a contract value, which was the existing contract value of up to £958,829. With this level of funding, based on the calculations that we use, this would allow approximately 9,988 patients to be able to access NHS dental care from the 1st of September. This is obviously subject to the capacity the patient needs and priority being given to the former patients of Bethcard Dental Practice. We received 4 bids one, which we were extremely pleased to receive, and this was for the total funding available and was on the basis to establish a new contract, a new practice actually in Ebervale from the 1st of April. And then we received a further three bids from other local providers, and this was for a proportion of the funding. The 4 bids in total did exceed the funding available, but the bid received from Bridge Dental Centre was for that new build in the area of Ebervale and was dependent on receiving the full contract allocation. The provider shared draft plans with the new build as part of the interview process that took place on the 21st of July. And this outlined that the new premises would consist of 7 surgeries, 2 of which could incorporate a 30-stone chair. The premises would be situated in Ebervale, just off the main high street, and are on the ground floor, which would allow for easy access. There's a large car park located close by, with bus and train links also nearby. This would involve 3 new dentists, an additional clinical team joining the practice team from the 1st of September, with the aim of this team then transferring to the new premises in April, providing the continuity of care for patients. The proposal outlined building works would commence from the 1st of December, with the fit out taking place and with the aim for the practice to open on the 1st of April. The proposal would ensure that NHS dental services will continue to be delivered in an area of high need in Blaenau Gwent and would offer NHS dental care to those patients affected by the contract resignation. The practice provided details around the interim arrangements where those patients could be seen in their existing practice, the Bridge Dental Centre in Newbridge. Recognising that there would be a transport issue, the Health Board was able to provide details of assistance available to patients as part of the community transport services available. The panel was satisfied that the practice had the appropriate workforce and suitable premises identified to enable the continued delivery of NHS dental care by establishing the new practice in Ebervale from the 1st of April. And they were also satisfied with the interim arrangements during that period. Recognising that Bethcar Dental Practice would terminate their existing contract from the 31st of August, Chair's action was obtained on the 12th of August with approval to award the contract. As a result of this, a number of actions have progressed. We've confirmed with the contractor that the contract has been awarded. We've issued notification to the patients affected by the contract resignations, which included details of the interim arrangements and those local community transport links. We are now continuing to work closely with the practice to finalise the new premise specification with a view to the practice opening in April. As access continues to be a significant challenge, there is also an opportunity to award the other 3 practices who also submitted high quality proposals their full allocation. And this would increase NHS dental access in Blaenau Gwent and Caerphilly from the 1st of September. And these were areas of high deprivation with high dental care needs also. The Health Board does have funding available within the existing GDS budget to commission the 3 NHS practices on a pro rata basis this year from existing non-committed additional funding. However, we would require additional funding from Welsh Government to be able to secure this on a recurrent basis to commission the additional activity. This was subsequently presented to Welsh Government, and since the paper was written, we have now had a meeting with Welsh Government colleagues to explore the potential opportunity to further enhance access to NHS dental care. And whilst they were very supportive of the proposal, they have confirmed that they are not able to provide any additional funding at this point in time. Unfortunately, we are therefore not in a position to progress with this opportunity at this point in time. However, whilst this is disappointing, we are extremely pleased to have been able to secure the ongoing NHS dental services by establishing a new practice in Ebervale.
Thank you, Victoria. At least that was very successful in a very difficult area. Are there any questions? Are you happy to ratify Chair's action? Let's hope we're just as successful elsewhere. Ewan?
Sorry, just around that funding then. So we haven't had the funding, but we have commissioned the dental services?
So we've been able to secure the contract, the new contract in Eberville now. So that is using the existing monies that was obviously the contract value of from the contract that was resigned. For the other 3 areas, this was an opportunity to increase activity within those existing providers. So we haven't been able to secure additional funding at this time from Welsh Government. The dental budget is already fully committed. So this will remain, and every opportunity that we do have, we will present this back for additional funding, which would allow us to increase capacity in those areas.
Okay, so we haven't committed anything until we've just stopped at that point.
Yeah. Yes, just for the establishment of the new practice.
Yeah.
Which is fully funded.
Yes.
Yes.
Okay, agreed? Yeah. Thank you. Thanks very much, Victoria.
Thank you.
3.2 Annual Welsh Language Standards Report. Sarah.
Diolch, Chair. Just check on that, please. Yes, it's working. Rwy'n falch iawn eto. I'm really pleased again this year to present the Welsh Language Standards Annual Report to the board for approval today. It's our statutory duty to provide a report on a yearly basis to review the work and progress that's been made in progression to implementing the Welsh language standards. You had an opportunity to review the report, which reflects the work undertaken to implement our bilingual skills strategy, concentrating on our workforce skills and communication to meet our population's needs. It reviews the work undertaken to support our primary care partners in terms of tangible steps taken to increase visibility of the Welsh language with our partners. And it also looks at the work that we've undertaken to support our communities, and in particular the work with our schools, really building a platform to increase our Welsh language provision through our future workforce. The report also looks at specific areas which is required by the Welsh Language Commissioner in terms of the number of complaints we've received. There have been 6 complaints received, and all have been resolved with our Cydymdeimlad Rights team, who have also been supported with Welsh language provision and also key performance indicators in terms of those responses. You'll see from the report that we've increased the knowledge that we have on the baseline competency of our existing workforce and their Welsh language skills. The report looks at the improvement that we've made over the last few years, standing at 65% of our staff who have been able to register their competency skills in our ESR database. So almost doubling our provision over the last few years. The report also looks at the training provision provided for our staff and also the partner iaith, the internal community that we have, which supports our Welsh language speakers to increase their confidence and their skills. The report also shows the number of jobs that we've advertised through the medium of the Welsh language. We recognise that there's more work for us to do in this area, particularly around our ability to proactively work at pace in recruitment. And to support this, we have recently recruited an internal translator. We believe that that will improve our ability to advertise through the Welsh language for those roles where Welsh is desirable or essential. And overall, I think the report presents a holistic and community-based approach to our implementation of the Welsh language standards, really supporting our population needs and the impact that language can have on patient experience. So the board is asked to note the improvements made and the progress made with the standards, and also to approve the report for publication at the end of this week. Of course, the report will be translated as well. I'm happy to take any comments or questions.
Thank you, Sarah, and thank you very much for explaining the improvements that we have been able to make so far. We must continue to strive to improve further. Paul?
I just pay tribute to the communication and engagement team. If we look on page 10, we look at the sort of the figures there of the medium and then the number of followers on sort of Facebook, Twitter and Instagram. I mean, 106,000 in England. Numbers are increasing for Welsh as well. So I think that the messages I want to give is I think they're doing an incredibly helpful work in this particular area and making sure we are compliant to what's required. And I think it's a very detailed and thoughtful report, but I just sort of picked up the fact that there's some really good work going on there and an opportunity to thank staff for their work on this particular area of activity.
Thank you, Paul. Louise?
Yeah, I'd like to say thank you to Sarah as well for this comprehensive report and for the team as well for all the work they've put in. It's just a question whether or not we'd be looking to recognise some of the work that's done around the Welsh language within the staff recognition awards later on, because I don't think we recognise that at the moment. I just wondered if this is an opportunity
Good idea.
to actually highlight it a little bit more for staff, because there's so much work going on.
Yeah.
And it's ongoing, and we really are achieving a lot, I think. So,
Good idea, Louise. We're happy to adopt that suggestion. Yeah. Pippa?
Diolch yn fawr iawn. I was really pleased to see this, and I think for me, the standards are one thing. We have to comply with the standards, but as an organisation, I think it's really good to see that we are going beyond the standards to try and affect the culture of the organisation, and I really wanted to, I guess, just add my congratulations and thanks how far this has moved along, and especially, you know, being in the southeast, we are not a primarily Welsh-speaking area, and so I think to have made these strides and the staff commitment to it, of the things that are beyond just the box ticking of the standards, I think is really important to recognise. So I just wanted to add my thanks really for the comprehensive work that's been going on.
Thank you, Pippa. Well done. Thank you. So we're happy to adopt it. Good. We'll see an even greater improvement next year. Surely better luck. Thank you. Can we move then to the compliance with the smoke-free legislation, please, Sarah?
Thank you, Chair. So this report is in two parts. The first part is the assurance to the board on delivery of the plan the board approved 18 months ago in terms of our acute hospital sites. And then the second part is about the plan for compliance with the regulations for mental health and learning disability units, which we had a 2-year grace period on. So the first part of the report, you'll see that it's all green, other than there's a couple of areas which I'll talk through. The board approved an engage, explain, encourage, enforce staged approach, and all of our conversations with the local authorities, who are the enforcement authorities, are very supportive of that approach. And the report outlines the approach we've taken. So engage, explain was everybody, but then we broke it down into staff and visitors and patients, thinking that we needed to demonstrate leadership through our staff not smoking before we could have a serious conversation with visitors and patients. So the report describes the process we've been through. We've now got an agreed protocol for issuing. After the smoke-free officers had a number of conversations, it then moves to, right, this is now a formal conversation, and if I have to have a second conversation, it will go through a disciplinary process. And I'd just like to thank staff side for their support of this approach. I think they felt we were taking a reasonable staged approach, and by the time we got to that stage, it was very much a case of all the staff have had plenty of opportunity, and if anyone's persisting, well then we need to follow due process. So that element is complete. With patients, it's been one of those tasks where the devil really is in the details. So, you know, can people actually get nicotine while waiting in our waiting rooms, you know, if they can't smoke? So we've now got the NRT available in our vending machines, and then we're it's available to patients on admission. The bit as it's described in the report now is the confidence at ward level. So when we move to the next stage, which is starting to enforce, we're going to do it site by site through the site leadership teams so that we've got the engagement of ward managers and we're able to have the conversation in advance about is everybody aware of the protocol, everybody confident. And then the proposed approach is that the smoke-free officers will be trained to be approved witnesses so that they can do the same as they're doing with staff, which is, you know, I've had 5 conversations with you. I'm now having another conversation with you. So if I do need to have another conversation, I will need to provide a statement to the local authority. They would then issue the fixed penalty notice. So I've been really concerned that this has got to be about repeat offenders, not about somebody who's just been bereaved. And, you know, so, and I think using our smoke-free officers enables us to do that, because if we go down the normal local authority contractor route, it could be we've just walked on site and we'll find everybody who's smoking. So that's where we've got to on the approach, and I think it's likely that we will start with Newport and our sites within Newport before moving to Torvine. So that's the plan for completion of the main part of the regulations. And then on the mental health units, the legislation is very prescriptive, and actually, as the report outlines, that when the division were thinking about it, if you're nursing an agitated patient, you can't keep them still in a designated zone necessarily. So we went back to the basics of this is about in patients who are not smokers being protected from passive smoking of smoke of patients who are smokers, and designing a system around that principle. The detail that's in the report, I put in a letter to the 5 local authorities who've all come back to say that they're content that those are reasonable steps, you know, in terms of implementing things at a reasonable pace. The one authority has asked the question about, you know, do we expect to get there eventually? Because that's a different thing. You know, if we think we're never going to get there, well, we should be having the conversation with Welsh Government. But we think we will get there, but just over a longer period of time. So we're going to provide smoking cessation support to people on discharge. And we're also going to work with the community psychiatric teams to provide smoking cessation support. And there are, you know, mental health service users have a high prevalence of smoking, and it's the right thing to be doing anyway. And then also, as we work our way through the estate strategy, each time we move a ward and open a ward, we need to be thinking that, you know, about being compliant with this legislation. So I don't think we're in the position that we think we won't get there. I think we're in a position that we think it's going to take us, you know, a few years, but we are going to improve year on year. And the local authorities are content with that position.
Thank you, Sarah.
Thank you, Chair.
Are there any concerns, comments?
Not concerned,
Yes, Shelley.
one concern. Absolutely support this report, and I think the approach that's been taken, particularly on the COOP sites. I suppose my query on that one is, why would we not just try and start the enforcement process, but, you know, what we're doing across all sites at the same time? Because I think, you know, I just can see people do visit the different hospital sites, and suddenly you've got enforcement, or more obvious enforcement, let's say, going on at Royal Gwent, and particularly maybe from a staff perspective, and then they find out that in Neville Hall nothing's going on. So that was my one question, Sarah. So do you want to, because I've got something on the mental health side as well, can I?
Yeah, good.
Yeah.
That's it. That's it.
If I pick, so I have been you know, I've always said it needs to be equitable, particularly for staff. It is equitable for staff because actually staff, we're applying the disciplinary policy equitably across. This is about the fixed penalty notices, and the answer is that the 5 authorities have got different approaches. So it's the enforcement agency is the authority, not us, and therefore we do need to work with the 5 authorities, and I think that level of confidence around the site's readiness at ward level is difficult to achieve in all places at all times at the same time. But it isn't intended to be over a long period of time. It's intended to be over a fairly quick period of time.
Okay, well, that's great. Thank you. I just didn't so much. And with the mental health, again, you know, I suppose the point you're making around you're working towards compliance. I think I do feel I understand what you're saying. That's why I read them. I've actually read the notice. I can't see how they're going to comply because of the description you give of the physical position. And I understand with the estate strategy and with changes, but I still think that we need to have a bit of a time scale on that because obviously that's quite fluid in terms of what developments are going to be made where or whatever, although you've obviously got a new unit potentially at some point, but that could be some time off. And so I just wondered, is there value in sort of at least going back to Welsh Government? I appreciate the local authorities are content, but to go back as one of the suggestions is that we just perhaps all say this is our goal. But I think the Welsh Government would want to know, are we talking about 2 years? Are we talking about 5 or are we talking about 10 years? I mean, I support the pragmatic approach absolutely 100%, but that was just my concern.
So, you know, I think the principle is that the site should be smoke-free and that we don't need a designated smoking area because that if we say that we're going to have that forever, we're saying that our mental health service users are going to have a high prevalence of smoking forever. And I think I think the way to get there is to reduce smoke prevalence in that population who are a defined population. But I do think there's, you know, as a board, we do need to make sure that every time we approve a new bit of estate that we are assured that we're moving in the right direction. So the two things together. My sense is it's 5 years. I don't think it's longer than 5 years. But you know, I think it's achievable in 5 years. But I would be reluctant to accept that we think we will always have smoking in our mental health unit at this point. And if we do get to that point, well, then we need to have the conversation. But I think at this point, we should be setting the goal that we won't.
And of course, sorry, can I just have a follow-up? So contrary to that, I do understand that position, but that, you know, again, could take more than 5 years. So I suppose I was surprised the regulations weren't drafted in such a way as that there is, you know, if the government can see that you've done as much as you possibly can in terms of, which you have, I think, in terms of where we are now, that there isn't some kind of exception that we accept where we are and we'll come back and we will review it in 5 years and see what you've done. Do you know what I mean? I was surprised that the regulations seem to be quite strict, you know, without any flexibility.
So the regulations were consulted on during the pandemic when the public health system was doing other things. So I think the point is well made, Shelley, and it's exactly the point that Torvine were making. I just think it's too early to make that call. And we've been talking to other health boards, we've been looking at what some of the private providers do, and I think at this point we should be setting the goal that we intend to be smoke-free, rather than we're going to build structurally in designated smoking areas in all of our mental health wards. And one possibility is that we may end up with smoking on some wards and not all wards, but ideally we get to the point that we don't.
Thank you, but with the clients having help to avoid smoking.
Yes, I haven't. So we need to support the service users to be non-smokers before they become at risk of being admitted, and so that the number of smokers being admitted goes down.
Louise and then Pippa.
Yeah, my question was around, thank you for the report, Sarah, and I'm glad you've acknowledged that staff side were in support with the process for the non-smoking policy. I got concerns around whether or not staff understand who the site leaders are, the leadership teams that are responsible for these areas, and who do they go to, and whether or not that is clearly out there for staff to be able to communicate.
So I'm referring to the site management, the operational site management arrangements, and working through those at the point that we are going to the next level, so that there's clear communication on the site and no surprises.
Okay, so I'm not sure whether or not there's clear leadership on all the sites within Aneurin Bevan at the moment, and what that's something that we're working through to make sure that staff know who's leading what. or looking after the sites. Sable has been a good example.
Can we have?
That's all. It's just a,
Okay.
just a
There's a big
concern.
issue about the
It's still ongoing.
site leadership, isn't
Yeah.
it? Plus making sure we're clear about who's there and what the leaders.
Yeah, it's a small thing, I know, but.
No, it's an important.
So certainly for the acute sites, we have had good attendance at the group from a representative of the site leadership group who's feeding back in
But it's all
regular
fine. We need
meetings.
to make sure.
Yeah.
Everybody knows. So we'll pick that up. Thank you.
Thank you for the report, and having been here 18 months ago, I think, there's been really great progress, and I absolutely support the report and what you said as well about encouraging people, particularly in our mental health and learning disabilities areas, to not be smokers in the first place before they come in, but also to encourage or help them while they're in with us. My concern around the 10-metre rule is if we were to create such a space, how does that affect our staffing? Because there's presumably a level of reassurance that staff need, that they can see the people who are in their care and make sure. So is there going to be an impact on staffing if we had to have something at least 10 metres away? And if that was true, then, I mean, if we're feeding back to Welsh Government on, these are some of the challenges because of the infrastructure of the of the buildings that we've already got, but also we have concerns. I personally have concerns about that kind of, how do you keep an eye on somebody if they're a bit further away? That's just.
So the pragmatic approach that's in the paper has been designed with the mental health division and particularly the nursing staff for exactly those reasons, Pippa. And that's why I said, well, let's move away from the letter of the regulation and let's design something that is the principle of what we're trying to achieve, which is that people don't have to breathe other people's smoke. So the division have co-designed this and have been part of presenting this to the executive team. So the division are absolutely content with what's in here. I think the point about should we ever get to the point where we expected to have all of this in place, I think is well made, and perhaps we do need to write to Welsh Government in terms of the regulations as written are not terribly practical. We intend to get there, and maybe the wording of the regulations could be reviewed to provide a more enabling approach to what was actually intended.
I personally think that would be very helpful.
That would be able to.
Yeah, we'll do that.
Thank you.
So are you happy to ratify this report and agree with the approach that's been taken when we'll write and advise Welsh Government on why we're doing what we're doing? Thank you. Could we move, please, to 3.4 cellular pathology? Leanne, you're going to do a double act, aren't you?
Yeah.
Who's starting?
I'm starting, if that's okay.
Okay.
Thanks very much for the opportunity to update on this. Obviously, the paper is there, but there's a few key issues I'd just like to draw out. I think it's a very important paper for us. Nicola's talked already about the prioritisation of cancer as a health board, and I think this is a very good example of us needing to do that. It's a very important service and it underpins a significant number of sort of cancer pathways. It's a service that's responsible for the processing of specimens and then the reporting of specimens. And we find ourselves in a bit of a perfect storm, I think, at the moment with the capacity that we've got available for this particular service. And there are some key facts, I think, just to tease out of the paper for your awareness. We historically have carried a backlog in relation to processing of histopathology or cell path samples in the past. That's normally run pre-COVID at around 1,500 to 2,000. But post-COVID and with the increase in sort of complexity that we've seen, along with, I think, sort of delayed presentations in particular and some of the demand that we've been experiencing more generally across cancer, we've seen a significant increase in the urgency profile which has resulted in delays for our samples. That's increased pre-COVID in 2018 from 46% to 62%. And we've seen, just for again awareness, I guess, sort of a similar level of increase in our cancer referrals, for example, in colorectal and in endoscopy urgency profiles. So this is something we're seeing consistently through our pathways. The issue that we've currently got, though, at the moment in this service is that we currently have a 4 to 5 month sort of backlog for our routine samples. And that is particularly relevant because in an audit that the team have undertaken, about 8% of our routine workload in cellular pathology is cancerous. So as it currently stands, there's about 670 cancer cases in our routine backlog that we have not been able to report in a timely manner. So in terms of patient harm and risk, it doesn't really get much more serious than this, I guess. And notwithstanding, I think, some of the other financial and economic arguments around why we would do this. It's important to note that we have exhausted all of our local opportunities. The workforce, it is a national issue, this issue in particular. There's a very comprehensive Get It Right First Time pathology report, I think, that outlines many of these challenges for us. But the teams are as stretched as they possibly can be. So we find ourselves in a situation where our only short-term response to this would be to outsource both the processing of the samples and the reporting of the samples. It is commonplace. I think that's another sort of key of consideration for the governance. There are other health boards that are outsourcing significant levels of cellular pathology activity as well. And as I've said, it is a short-term option for us to recover the position and the backlog we're carrying whilst we work up a more sustainable solution, because I think status quo is not viable for us. We must sort of resolve this. There are some very significant demand and capacity shortfalls anyway from a sustainability, and we're working through that, but that is not sort of the main purpose of the paper. Just in terms of being very explicit, there is a further sort of financial risk, obviously, if we make the decision to proceed with the outsourcing to the tune of over £800,000 as outlined in the paper. And I think in our executive conversations on this, I think this is a very good example of us needing to prioritise a spend or a requirement to spend in this area with a view that we need to pull back on other areas of spend because of the risk that we're carrying here. And two key aspects of that, I think, just from a financial perspective, if you look at the Getting It Right First Time report, the litigation costs around this are very significant. Average claim cost is about £146,000 for a histopathology sort of litigation claim, which would just be 6 or 7 cases we would have to recover with a backlog that we have. Not least the delay in terms of the treatment the patients will receive. If they are delayed by 6 months in relation to sort of their cancer treatment, their treatment becomes much more complex and costly, let alone the patient risk, which I know will be most sort of concerned about in relation to this. I think important to note sort of the current performance, that the standard that we expect in relation to turnaround for these samples is 7 days. We should be hitting 80% of that. We're currently at 12%. And with investment in relation to this, we would anticipate being able to deliver 75 to 80% turnaround at the 7 days. And we would reduce our current 16 to 26 week routine backlog to within the 6 to 8 week parameters that we have previously sort of delivered on. Final point I would just want to make, really, in terms of sort of the assurance, there is a very rigorous process in place in relation to the governance for the outsourced provider. The team that are leading on this have a significant amount of experience for outsourcing, having done it already in a standardised way in radiology. And I know that will also be scrutinised via Cancer Board. And we are also sort of assured in terms of the procurement process. We would be able to deploy a solution within weeks, not months, because I think it's very important given the risk that we're carrying for this particular for this particular issue, but would really welcome the board support in proceeding with the option to outsource to help us clear this backlog whilst working at the sustainable solutions, notwithstanding a full and complete understanding of the financial pressures that we're currently experiencing. But I think this is a choice that we have to make potentially at the expense of other areas. That's as much as I wanted to say. James, is there anything you would want to add in terms of your cancer lead and medical director role?
No, I think except then to provide assurance to people that this is just one bit of the work that you and I are doing together on the cancer pathway. Histopathology is incredibly important because it is a common point for all cancer pathways. We see a significant improvement in our cancer performance. We'll see a significant improvement in our cancer performance when we address the histopathology issues, but it's not the whole story. And we are working at a structural level at all steps on the cancer pathway to make sure that our patients get the very best service. I think if I were coming to this paper with a fresh pair of eyes, I might wonder quite reasonably why we had got into such a bad position so quickly. And I think there are really sort of two answers to that question. The first is that in some of the more complex pathways, such as colorectal, there has been a sustained 46% increase in activity over and above pre-COVID levels. And these are appropriate referrals into the colorectal pathway. We are maintaining our same sort of conversion rate to confirm the little diagnosis. We're not seeing any sign of that tailing off, and it was completely, as yet, it's completely unexplained. But it is an area that we're having to address. And then the other thing is to the rapid development of cancer as a field of medicine. In the past, the sort of processing samples was all done in-house, but now we have cancer genetics, cancer genomics, and staining for antibodies as part of providing personalised healthcare to patients. Because of the complexity of that work, a lot of the processing within Wales has been centralised in what are state-of-the-art facilities that are not available in many parts of the world. So that's fantastic for our local population. But I think perhaps when those services were planned, insufficient consideration was given to the fact that the funding has been centralised for these services, but the processing of these samples still occurs in local health boards. So what it means is that the number of patients we're seeing overall is back at or just above pre-COVID levels, but the processing time for each of those samples has doubled. So essentially, we've seen a doubling of workload being taken on by a shrinking workforce in a physical facility on the Lord Went site that's simply not fit for purpose. So part of the long-term work we're doing is also an options appraisal of much better fit for purpose pathology buildings and things, but people will appreciate that that takes time. And that's why this outsourcing business case in the short term is absolutely key to ensure that we give the service to our patients that they deserve and require.
Thank you, James. Obviously, this is a very serious issue of patient safety and needs to be considered as such. Are there any questions? Shelley?
Can I just say thanks to Leanne for obviously clarifying on the financial aspects, because that is, I absolutely support entirely. I think we have no option but to do this. And obviously then the clarification from James about, my question was going to be, how have we got ourselves into this position, presumably over a fairly short period of time? In terms of finances, you say we will have to obviously look at other areas. I think as a board, we need to understand where that money is going to come from, or how we're going to try and make it as soon as possible. I think we need to have more clarity from reports like this about, even if they're early developing plans. Is that okay?
Absolutely. I think sort of when we've talked about this as an executive summit, our patient risk versus our financial risk. And I think there is nothing more important than this. We do need to be more mindful of hidden costs. The litigation, part of the reason I brought in the litigation cost actually is that we don't very often see that directly in relation to the cases that we present, I think, to execs. and the cost of the additional complexity, of not treating some of these conditions early.
And it's quite clear that the current levels of service they're managing to achieve are neither acceptable nor sustainable.
Bill?
My point was the timing issue really, Chair. And I think we're probably looking at I would say a 2-year job rather than 6 months at the outset. I mean, if we're talking about performance, we should be looking at 80%. Are we talking about 12%?
Yes.
So that sounds pretty serious to me.
Yeah, quite.
Yeah, and if you look at graphs, you'll see how rapidly the situation's deteriorated. So October 2020, we were actually meeting or just short of meeting Welsh Government standards for the 62 cancer pathway, but that was because of the significantly constrained demand during COVID. So what we've seen really is demand has increased to greater than COVID levels as it's unmasked all of the sort of structural weaknesses of the services, which were around workforce, facilities. The actual way in which the staff is working is incredibly impressive. I don't think that people who are working in the pathology services now could be working harder or more effectively or efficiently. This is not a problem that will be fixed by working harder. We need to work in a completely different way.
And some of it's probably technology led, isn't it?
Yeah.
It is.
Ultra modern technology that maybe we will never be in a position to buy ourselves. It may be an outsourcing model mixed with some in-house service, maybe in the future with something like that.
Yeah, and I think one of the areas that people often don't realise is histopathology, if you like, is a sort of almost like an artisan specialty. There are some very skilled technicians who are required to prepare the samples for doctors, and there is, and until relatively recently, there was not a strategy for how we grow our own and bring on these people in a very obscure level of science that is really not very well known to the public. And one of the things that really impressed me by our local histopathology services is they've been thinking about this for a long time, and they have a pipeline of people who they are trying to develop into these roles. But the thing that hugely worried me is, as medical director walking around the department, was looking at all of the technicians, the very skilled technicians who are working on these skilled benches. They all look like me, and they're not going to be around for a huge length of time. What I was not seeing were lots of people without grey hair doing that work. So, workforce is going to be absolutely key in making this sustainable for the long term. That's a theme around a huge number of our health board services. We need to be a really good employer. We need to be really good at bringing people on board and then look after them really well so that they stay with us.
And this could be one of the positives that comes out of these big problems, isn't it?
Yes.
Yeah. I mean, we could become now quite transformational because we've got a big problem.
Yeah.
We deal with it in a transformational way, which change the whole service.
Yeah.
So maybe there will be benefits in this.
Yeah.
It's difficult to look at the minute, but I think the outcome we could end up with something so much better than what we've got as a result of the difficulty.
And I would say that one of the, sorry, Leanne, I would say that one of the things that Leanne has led on that has now come to fruition, which is already showing benefits, is the bringing of pathology services, all of the pathology services, into a single division. And that has allowed significantly more focus on pathology services. And we've seen a step change in the rate at which work is being done to turn the situation around. And that's down to my colleague here, who I think did a fantastic, complicated bit of work that's actually really making a difference now.
Good. Got Helen and then Richard.
Thanks, Leanne, and very detailed report. Obviously, I certainly support what you're doing. Just for clarity, is it the non-cancer, possible non-cancer specimens that are being outsourced, or are you planning to outsource everything? Just to fit that timescale.
Yeah, it won't be everything, Helen. There's clinical conversations ongoing in relation to sort of which of the samples and specimens should be sort of outsourced. We have been undertaking, just for awareness, sort of discrete outsourcing now as a result of the endoscopy insourcing that we're doing anyway, is a discrete area of work. So that's currently being worked through with the teams at the moment, but not everything will be outsourced. We'll still retain our internal capacity, obviously, sort of around that.
Obviously, one of the key roles of pathologists these days is involvement in the multidisciplinary meetings and being able to provide that dialogue and conversation, which you probably can't get from an outsourced facility. But definitely support what you're planning to do. Thank you.
Leanne and I met with the commissioning team recently, and as Leanne says, they are very experienced, and the areas of concern that I wanted assurance on, which was around quality, incident management, governance, they were all over it, and they were already requesting a detailed specification from the provider who we've identified. Though, as far as we can tell on the sort of commissioning framework, there is only actually one provider who's able to deliver this service, and reassuringly, they do not seem to be finding it unfamiliar to be having lots of questions asked about governance of the service, because essentially we need to make sure that our outsourced service provides the same quality as our own. So
don't create more problems. So, thank you.
Thank you, Richard.
It's a relative subject for myself, and naturally I fully support the report. And it's not a get at the report itself. I think it's possibly a way we do business altogether. Was a throwaway line in the report about 876,000 pounds for this new service, additional. You said yourself, notwithstanding the economic reasons, and then you've got to reprioritise now what you spend on. I'm not dealing specifically with this report. This is financial committee chairman's head on, and I will be looking at this further in the committee next week. But I think we have an issue where we are, and rightly in this case, I'm almost undermining my own argument, but rightly in this case, spending this money. Had you given us the reassurance in the report that you've given us verbally today, the litigation costs and something else that I've written, the future treatment costs of patients, which I totally understand, and Phil's word transformational. This is an opportunity to provide something in the future, but I think it's a systemic of reports we receive, and attitude to finance is probably the wrong expression, but we keep taking things on and there's not the resource to cover it. I am not having a pop at this report at all. I fully support it. We'll put two hands up to it, but reports coming to us really need to show and reassure us as board members that if we are going to do this, and you actually said reprioritise, so I appreciate it's in your mindset, that there's something else we're going to have to turn off, or we're going to have to find funding from somewhere else. We've got a report later in this morning's board showing at the moment 17 million deficit. Whether that gets worse or better, we don't know. But this is now 876 onto this. 876 I fully support. I don't think I can say that enough. I think I've said it 4 times. But we really, as a board, I think Ewan has asked 2 questions in previous reports. It's just Are we sighted on the finance? Are we doing enough about this? If this, what aren't we doing? Where are we driving home the pressures? It's not something I expect either of you to answer today. And for the final time, I will say I fully support the report.
Thank you, Richard. Ewan?
Richard's taking the words right out of my mouth.
What a surprise.
Yeah, I just want one little bit of clarification, I guess. I assume this 876 is part of the current cost pressures that we've got. This will be in addition
Correct, yeah.
to those. So when we get onto that report, that's another $1 million on top of that one, I guess. And the one thing then I was going to add on to a bit of Phil's point there, in terms of when we come to look at how we want this service to look, coming from my old background, whenever we kind of hit problems like this, it was always two other questions came up of whether or not this is something that we should be outsourcing, full stop. You know, can somebody do it better at a better cost? Are they more efficient? Have they got economies of scale? If we think we can do it better internally, then is it something we should insource as well? You know, should we create the centre of excellence? So, you know, when we look at it going forward, so two things possibly that we should think of how we develop the service, and that goes for pretty much everything as well. But I'm with Richard, I fully support it.
Yeah.
But the question of what do we drop then? Because obviously we are in a very cash-strapped position.
I think one of the things is, well, it's probably worth highlighting two things from the conversation so far. If we want to truly transform cancer services, that sits with Sarah and her team of actually transforming the things that contribute to development of cancer within our populations, like smoking cessation, adherence to screening regimes. All of these things are the thing that will actually be transformational in our numbers. It's turning off the tap rather than making our processing of people with avoidable illnesses more efficient.
So that possibly comes back to the, well, so if this is something we hope to see just decline, outsource it, give it to somebody else and let them take the cost as it goes down.
And that's a nice segue into my second point, which is that the point was being alluded to was that when a pathologist looks at the pathology sample, they are providing a clinical opinion. It's not a yes or no answer, and there's nothing written on there saying cancer or not cancer. And I know that that's obvious, but sometimes it's a difficult decision, and there needs to be a clinician to clinician conversation. And there is international outsourcing. You know, we could be sending digital images to South Africa, but you're not going to have the pathologist sitting in the room making difficult decisions about the difficult patients, which is what MDTs are for. So, you know, there may be elements that we can outsource, but we do need to retain those skills internally. And we also need those people into Horizon Scan to help us to try and imagine what pathology services of the future will be. My particular area, lung cancer, is unrecognisable when I started as a consultant 18 years ago. And some patients who had life expectancies measured in weeks, because of the treatments that are supported by the science we're talking about, that their cancers are becoming long-term conditions. And the health service is not yet really adapted to cancer, moving from a significantly life-limiting pathology to a chronic disease, but a chronic disease that requires quite intensive management. So, you know, it's a fascinating area, and that's why things like this are so important. And we run into these problems because of the block contract nature of funding. So we've seen a doubling in complexity of the cases we deal with no increase in funding. So you are quite right. We then have to find other parts of the work done elsewhere in the health board outside sort of cancer that we need to turn off, whilst at the same time investing in public health, because that's the only way we can get out of this fix 10 years down the line.
Yes, and I think you've touched on, other people have actually sort of touched on the point that I was going to make anyway. First of all, I think in terms of thinking about patients and them getting the results that they need to get as early as they can, it's not just about the amount of money it's going to cost us down the line with more complex. This is about how it affects people's lives. And so for me, this was a no-brainer to support. I know it costs money, but at the end of the day, we absolutely need to do this to get back on an even keel. But in terms of the outsourcing, I wondered whether or not it's worth us putting some work into is there an element that we can outsource? An outsourcing company, you would expect to have, you know, we wouldn't have to spend money on the latest technology or the latest training in certain areas. So it's a question of, is there a pipeline that we can outsource and a pipeline that we keep internally in order to get the best outcomes for people, but also put less strain on our own department and our own staff. And I just think that's something, if we can, you know, if it hasn't been looked at already, if we can look at that.
No, that's exactly what needs to be looked at.
Paul?
I think the elephant in the room is the issue of the budget. We have a budget and it's a finite budget, and we know that the demand is increasing exponentially, but we've got a limited budget. And if there are requests for special cases, and I think this is a special case, and like Richard, I support it, then we have to look at yes, we support this, but what won't we be supporting? What we haven't got really is, what are we going to have to reduce? And I think it's a very difficult conversation with the public, because if you talk to the public, they want everything. But I think if we've got a limited budget and a finite budget, and we have to prioritise, cancer is an area that I totally agree with what James has said. I think if you looked at cancer 10 or 15 years ago to where we are now, people with cancer living much, much longer than they were years ago. It's a different world. And I think from our perspective, what we need to look at is what's best for our communities and to support the priority needs. But ultimately, we're going to have those difficult conversations and have a plan, which I'm sure we'll be discussing at some point. But I think that, or to say to government, you know, health is a top priority. It needs more funding.
Yeah.
And if we can't have the money, then of course, then there's reduced.
We have to make choices then.
We have then choices, and it may be we have to involve the patient conversations and say to the public conversations about, you know, this is the budget we've got, and these are the you know, what we need the funding costs, and what do you regard as the priorities, or what do we think are the priorities, and have some options. But I think we're going to get to that stage with a number of requests today for funding. I would fully support. I have no issues with anything that's been asked for. The other question is, where's the money coming from? And that's the question. And I think it's probably something which needs to be said. And I think we get in the mood music really. We want to do what we can to help patients.
Yeah, it's just to summarise some of the key points. The only bit I don't think has come out strong enough is our sustainable solution is more than just our health board, and it's a top priority on the regional discussions and the national agenda. We've talked for many years about needing regional pathology. We've just never cracked it. Nobody's wanted to do it. I think picking up Phil's point, I think the position we're all in, and absolutely, Cwmdab, Morgannwg, Carbon Vale, all in the southeast are facing exactly the same issues. And we, as a minimum, need to do something at a regional level as part of the sustainable solutions. And there's lots of work going on around workforce and training, but there is a bit of a reinvigorated focus on a national pathology strategy and what does that mean for this region.
Yeah.
So I would expect us not trying to fix this problem on our own. It absolutely needs a regional, but recognising that the pace of that is not going to be the same as what we need to do now. And you know, the financial discussion is a really difficult one. We you know, and I think understanding the scale of how this problem has emerged, as James described, this has been very quick to deteriorate for the reasons James explained. But you know, putting it to the reality, I signed an MP letter. So if someone was waiting 6 to 8 weeks still, and I think that was probably a more urgent. Imagine waiting 4.5 months for your biopsy to find out you had cancer. Let's turn this into B&U. It is just something that none of us around the table would absolutely want to tolerate. And I think that the case was 1.5 million at one point. Leanne and the team have worked really hard to look at, you know, how can we do this as effectively and as efficiently as possible within the ability to do that. And the conversation we had is, when we get to the financial discussion, when there's lots of other pressures in addition to this, what are the choices we need to make? And we'll have that discussion later. But when you read this, to think that we could have hundreds of people not diagnosed with cancer if we got this in place is just, you know, it's heartbreaking, isn't it? So I think it's, you know, that's where we've come from as an executive team. But absolutely, we need to have that discussion in the financial context in terms of what are the choices we've got and what challenges we're facing, which is much bigger than this one issue, isn't it? So I just thought that for the regional planning piece is fundamental. And I'm hoping the situation we found ourselves in now will
give us the drive for a regional solution that we've just not managed to solve previously.
Well, you and I have a meeting with our colleagues later today, and we will certainly bring that up then, because it has been ducked, really, hasn't it, for the past couple of years. Okay.
Yeah.
Sorry, Anne, can I just add very quickly onto the point that Nicola's made already, just again for sort of reassurance. So we have reached out to our regional colleagues around actually doing a joint piece of work for outsourcing, because they're outsourcing as well. I think the ones for Wales might offer some sort of financial sort of benefits, even in the short term piece. And part of the reason the case in front of you is only until the end of the year is to allow, I guess, us to have some of those regional conversations, because we don't want to come up with a solution that is insular to Gwent when it is a much broader issue that offers opportunity to innovate and transform sort of our services. And I think, again, just for awareness, the team are absolutely in the space that technology, digitization of this service, and even sort of some of the AI type sort of environment is where we need to be going with this. And our teams in the Clinical Support Service Division are really pushing hard at that regional sort of collaboration agenda, because we aren't going to focus on ourselves. So I think it's to reassure the team are engaging with this agenda. There's been rigour throughout in relation to sort of the financial situation we find ourselves in, notwithstanding the importance of this from a patient safety perspective. And again, just a note, coming back for an update in January won't be an issue for the team. There'll be weekly performance sort of monitoring of this particular area of work from now on.
Thank you.
Then just to provide a sort of final reassurance, I think it's inevitable that many of our services we're going to need regional services, and we're going to need centralisation just because of quality workforce cost. But in all of those discussions, we're acutely cognizant of the constituents who Richard mentioned earlier, who, when the dental practice in their town closes, can't afford the bus fare to go to the next town. So we have to find a way of centralising services but delivering them locally.
Yeah.
And that's the challenge that we keep bringing up in the regional meetings we're having, because, you know, some of the initial discussions, because they're easier to plan, was, you know, you put a warehouse somewhere on the M4, but the reality is that an awful lot of our patients will not be able to access that. So, you know, there are healthy, robust discussions going on at the moment.
Thank you. So we've had a well-presented case for a really important issue. The sense in the room is that we accept this recommendation, bearing in mind that we are very concerned about the resourcing of it, and we take up the executive team's offer to obviously investigate the costs and where they're coming from. This is of such critical importance for patient safety and outcome that we cannot deny this case. And are you happy to agree it? And we will have an update in January on what the alternatives might be and what we next need to do about the situation, because we cannot get into a situation like this again where there are delays. And I know it's sort of hurtled itself towards us, but nevertheless, we need to be prepared for that. So thank you. 3.5 South Wales Cochlear Implant and Bone Conduction Hearing Implant Device Service. Chris.
Yeah, so hopefully this is a relatively straightforward paper. It's essentially seeking permission to move to a period of targeted engagement on a service change. It affects, so cochlear implants are really amazing things. I'm best friend of cochlear implants, so I advocate for these, that essentially potentially restore hearing through giving access to sound directly into the nerves. And bone conducting hearing aids are for people who can't necessarily tolerate existing airborne hearing aids. It's a relatively small patient cohort, so it's about 120 referrals a year. About 50% of those go on to actually have the access to the implants. But it is life-changing for that population of patients, and we're talking about restoring hearing to that cohort population. So really important service. As we see with many service changes, and as we've just been discussing, the rationale for this is about sustainability, standards and staffing. So thinking about how do we provide a more equitable provision, how do we meet the standards that are there and set out by the Royal Societies, and how do we provide a sustainable staff base for delivery of the service. WISC have worked through the process, worked with clinicians and worked with the Community Health Council in developing the documents here. Proposal and the preferred option being put forward is for a single site model for delivery of both cochlear implants and the bone conducting hearing aids. It's currently delivered across a number of centres, but with an outreach support model for exactly the points that James just talked about actually you may need to go centrally for the treatment element, but can we deliver those outreach parts as close to home as possible? So the proposal is to go out to targeted engagement. It's targeted engagement because of the size of the patient cohorts. We know who the people are on the waiting list for this service, and we're trying to target those people in particular. So it's just seeking support to push on with that engagement period. And it's already been supported by the Aneurin Bevan Community Health Council.
Thank you, Chris. Are there any questions about this? I just have one. This is not a very large service. Is it going to be sustainable?
That's mainly the rationale for the centralisation and pulling it together. So there is a requirement to at least 15 procedures a year to maintain your skill level. Yeah. So by centralising, they should be able to maintain that standard in the number.
Did WISC look at any alternative providers in order to sustain the service?
Yeah, so as part of the clinical sessions, they did have those discussions, and I know in the past we have outsourced to Bristol and Bath, I believe they used before, so it's part of the consideration, but I know there's recognition from the clinicians, they believe they can provide it sustainably locally.
Okay, and is it going to be cost effective?
So one of in the sort of three areas they looked at, so clinically, the clinicians weren't necessarily supported, but then they did have that independent financial assessment. Yes. So we wait to see the financial assessment that comes with it, but at this stage it's about making the decision and supporting that engagement period about centralisation, and then we'll work through the options appraisal, the cost analysis, etc.
Fine, thank you. Any questions?
I just think it's a very thorough report, and it was good to see the questionnaire as well, to get some feedback from patients. And if the CHC has been involved, as well as the voice of the patient, I think it's very comprehensively done and well done.
So we're happy to accept this proposal for engagement targeting.
Yeah.
Thank you. Okay. Thanks then, Chris. Mental health and learning disabilities, residential care and domiciliary care proposed provider uplifts. I think Sandra was going to present this.
Yes, thank you, Chair. The object of the paper that I'm presenting today is to seek approval for the agreement of the 2022-23 fee uplifts for the residential and domiciliary independent providers as used by the Mental Health and Learning Disabilities Division, so that they're able to continue to commission care from the independent sector. The proposed increase is in line with the methodology the Health Board has used previously and that was originally agreed in 2015. This adopts key elements of the NHS Continuing Healthcare weekly fee structure and is aligned to the rates already agreed for the complex care service and is based on rates already agreed by our local authorities. By way of background, from April this year, there's been an increase in staff costs for services provided by the independent sector, following from a number of factors which I'm sure we're all aware of in terms of cost of living increases, general inflation, the introduction of the real living wage, and the limited supply and increased demand for staff in the health and social care sector. These increased costs have led providers to request fee uplifts for commissioned care from the health boards. Within the domiciliary care sector, there is a shortage of, shortage of staff has at times reached critical levels. Since 2020, there has been a consistent increase in the level of demand for domiciliary care services. The market has attempted to meet this rise, but continues to face considerable challenges in recruiting and retaining staff. As you know, these issues are not particular to Gwent and have been experienced across Wales and the UK. The residential care has acknowledged that individuals funded by the Health Board have more complex needs than those funded by the local authority, and therefore an appropriate fee increase is not achieved. There is a risk that providers will take up contracts elsewhere, for example, with the local authority who have already implemented an increase. There is a financial challenge associated with this increase in fees, and in order to mitigate some of these costs, the Mental Health and Learning Disabilities Division have implemented some cost improvement schemes, which include the repatriation of patients into our wards where we can accommodate the needs, stepping down of patient care where appropriate, and a review of packages to ensure individuals' needs continue to be met. The table on page 4 summarises the financial position for the division, where the proposed increase of 12.38 for domiciliary care and an average of 12.84 for residential care, along with the framework provider fee uplifts agreed nationally, equates to just over £1 million. This is a cost pressure to the division, of which 845,000 has already been included in the financial forecast in month 4. However, there is an additional 238,000, which is an increase to the current forecast. There are several potential risks in not approving the fee uplifts today, as our existing providers may choose not to accept further commission services, and this will have an impact on patient and carer quality, outcomes and experience. There would also be an impact on the wider system, for example, the potential for more hospital admissions, an increase in the number of delayed discharges and patients being placed outside the health board area. Other risks are noted in the paper. In summary, the board is requested to support the proposed increase in fees for both residential and domiciliary care in line with the approved fee methodologies, noting that the acceptance of the proposal means an acceptance of an additional 238,000 spent to the divisional forecast. Although it should be noted that when the complex care fee services increase were agreed a few weeks ago, this resulted in a £200,000 saving compared to forecast. So across both divisions, it's almost cost neutral for the health board. The board is also requested to note this increase in fees is additional to the original IMPT forecast, and to note the wider actions being undertaken within the division to try and mitigate part of these costs.
Thank you. Did you understand that?
No, I didn't understand.
Could you just elaborate on your last comment about cost neutrality? I am, as I've understood it, we are going to manage this within the division, from within the resources.
Yes, yeah. There was a cost. The fees were agreed for complex care a couple of weeks ago, and because of a slight change in methodologies, that resulted in a £200,000 deficit in forecast, so cost saving. So between the two divisions, there's not much of a financial effect.
Can I just clarify that? Because I think what we're saying is it doesn't impact on the forecast, but is going to be overspent.
Yeah.
Is that right, Rob?
Yes.
Right,
So
yeah.
in terms of Chris O'Connor's executive portfolio, it includes complex community care, which has had a favourable impact against forecast, £200,000 or thereabouts, and this proposition for mental health has an adverse effect, broadly is neutral.
But it's neutral on the forecast, not on the base.
That's what's still in, that's in the end.
So the forecast was 800,000 plus. Yeah. It's now gone to over £1 million, but 200,000 that's been clawed from everything else. So we're still within the forecast increase.
The forecast is the same, not against the budget. That's
And just
sorry,
unfortunately, sorry, Sandra, I was just going to say, just to confirm, so the request is for board approval of the fee rate, not for investment, not for.
Yes, that is to agree the uplift. As I said, most of the our local authorities and the other parts of the health board have already been agreed with the fees. So this is just the last part of that process.
Nice. Okay, thank you. Comments, views? Are you happy to adopt the fee level?
Sorry, just for clarity then. So the cost that we're looking at, the challenge we've currently got, the cost that won't change because of this. It's already built into that and at the end of, but we're still at £1 million over what the original IMTP was. Is that right? Or are we the 800 over the original IMTP? In this area?
Checking the numbers. I think it's the 800. Yeah, so we've estimated the forecast cost to be approximately £1 million above the IMTP. The division currently estimating 800 aligned to that. This now takes us from, 800 was in the IMTP. This is £1 million now as a revision. That's the 200,000 adverse shift. As far as mental health CHC is concerned. When we consider community CHC, which is a different division but still sits under Chris's portfolio, they've done a similar exercise, but they've managed to get a better fee rate than they anticipated in their IMTP estimates, which is the contra of 200,000 favourable.
So we're up that 800,000 from the original IMT. Is the cost challenge we've got there. So.
Okay. So I think just an important point to raise, because we are trying to understand where we are from the forecast. But if I'm right, Rob, in terms of the table that's in here, this proposed fee uplift is costing us £3.7 million. Albeit we expected that, we factored it into our IMTP, 2.6 million of it, because we took into account the real living wage inflationary. But the important point is that this is costing us 3.7 million. It's very consistent with what we've done in previous years. It's just ended up costing us more than we thought. We planned for 2.6, it's costing us 3.7. And then there's a bit of variation in terms of how that factors into the forecast. But the important point is, this is costing us money because of those inflationary increases, and to make sure we align with our local authorities. So it's trying to make sure we understand what is the gross position in terms of increased cost above last year versus then what's factored into the divisional position, the IMTP and then the current forecast, which is where it gets a little bit complicated.
Yeah, but obviously the 800,000.
Yeah, but most of this is absolutely in the forecast anyway.
We've had a number of projects that they are asking for 800. There are a number of things that we are.
So this is what we're saying is fairly consistent within the forecast we provided, albeit this above the IMTP and above what we spent last year.
It is, Jim. Can I raise that there's a technical issue in here for me when we talk about the components that are pushing the cost up. When we talk about real living wage, for example, most of these calculations have been done within an environment of continuing healthcare. And when you speak about continuing healthcare, those rates significantly were always above real living wage anyway. So providers shouldn't be using real living wage in any shape or form when we have a continuing care argument, because the rates that we were paying were far in excess of real living wage.
I'm not able to sort of comment on that currently. I mean, in terms of how fees levels historically were set, from my knowledge, it is, as you say, is based on usually agenda for change rates in the NHS. That's usually what they're based on.
Yeah.
So yeah, in terms of that context, I would agree.
It's just the language that we use for it. And providers, I'm sure, when they come to the table, they banter about real living wage. But actually, if care workers are providing continuing health care, they should be paid far above minimum wage, which the real living wage was meant to deal with in any event. So this real living wage argument, I think, is a nonsense one in a continuing care environment, not in a local authority environment, because they don't talk about continuing health care.
Yeah.
I mean, they talk about basic domiciliary care where the real living wage was a real issue. But in our world, continuing care is of a different level anyway, in terms of what we do.
Sarah?
I was just going to make the point about the that global economic situation where people need to be rewarded in care roles, which isn't necessarily the right point given that what Phil's just said. But I think in terms of our forecast financially, we need to work on the basis that as an anchor institution, we need to be supporting the population to have a living wage and fair work.
Yeah, I don't think we're questioning that. So are we content to agree the uplift in the fees suggested? Yeah. Thank you. Thank you, Sandra. Can we move on to a review of the current arrangements for midwifery-led services, please? And we're joined by Linda, Claire Lippitz and Jane Beasley.
Thank you, Chair. Just a few short points for me before Linda takes you through the report. Clearly, this is an important review of the position of maternity services following the previous report that came to the board in July. And I think it's really important to note the improvement in the position for patient safety following the arrangements that were put in place at that time. And a big thank you from me to Jane, Linda and Claire for the work they've done on looking at how we improve the safety in the unit.
We've continued to listen to the staff. Linda and I met with the staff recently, and again, we're continuing to listen to their concerns and ensuring that those are brought forward. But I think it's important to note that what we're proposing today is not a permanent position, but an extension of the interim arrangements to maintain that patient safety position. So Linda, do you want to just take the board through the paper?
Yeah, thank you, Jenny. And as I say, if I take you through the paper, and I'm sure Claire and Jane can provide any clarity and hopefully between us answer any questions in regards to the report. So today, the purpose of the report presented today is to review the current arrangements for midwife-led services. In response to the staffing deficits with maternity services, highlighted in a local options appraisal paper, which was reviewed by the exec team in May 22. You'll be aware that a temporary service change was introduced in order to maintain safe services. Since the introduction of the temporary services, we have had 2 updates have been received by the execs on the 23rd of June and the 12th of August, just to ensure that the temporary arrangements were appropriate and maintaining safe maternity services. This report provides a further update on the impact of the change in the service provision, which commenced on the 9th of May, together with the current staffing status. And the report also provides potential options to consider in regards to sustaining services and effective obstetric care. Just to provide some background and context with regards to maternity services, it's been acknowledged throughout the service change that women must have the opportunity for home birth, the opportunity to give birth in a freestanding midwifery-led unit, and an alongside midwifery-led unit, or within an obstetric unit. So when the GH opened, it saw the centralisation of obstetric births within GH, and that was supported alongside a midwife-led unit, and additionally midwife-led care births close to home was also supported across our 4 sites. The clinical future model for maternity service was based on 6,000 births per annum, with an expected caesarean section rate of 25% and induction rate of 22%. You'll see from the information provided that obstetric-led births at GH are slightly lower than we projected. However, the acuity and complexity of the obstetric-led births and the requirements for babies' observations, antibiotic medication have actually increased overall care requirements and has also increased the length of stay. Within the report, you'll see some comparison figures over the last 4 years in relation to caesarean section rates and induction rates. Additionally, the staffing model for the GH across the service was based on the projected number of births, and the report highlights the projected births versus the actual in 2021. It also demonstrates the demand for AMU births at GH is in sharp contrast to the underutilisation of the freestanding midwifery units. So in response to the significant workforce challenges and to maintain safe services, the following was agreed in May, and that agreement was extended until October 2022. The arrangements that were agreed were the temporary closure of the birthing units at Neville Hall and RGH, the maintenance of home births and births at Yab birthing pool with a risk assessment to be undertaken on a case-by-case basis, and the conversion of YYF to a birthing pod from 5 p.m. and overnight instead of staff 24/7. We also had agreement at that time in regards to incentivised pay in order to increase our midwife availability. The service redesign allowed action meant that there was no requirement for 24/7 midwifery cover out at YYF. And this actually released 4.4 midwives and a healthcare support worker to support midwifery activity across the service. So if I can provide you with some feedback from we introduced this change in May. What we have seen is there's been no compromise in women's ability to choose their place of birth with the maintenance of all 4 birthing options. Births have continued to be supported at Yab and YYF with no reported untoward outcomes. There has been no increase in births at home or en route to hospital, and no concerns received by the division from women and families about access to midwife-led areas. No overall increase in births at GH, and the The information provided within the report is a normal variation and is noted in keeping with anticipated booking numbers. Safe service have been maintained at GUH and across community with better targeted workforce to areas of clinical demand. YYF midwives have supported day assessment activity to prevent admissions to GUH. We have not seen an increase in transfer rates from YYF to GUH. The reduction in roster hours at YYF has resulted in GP clinics being covered by substantive midwives, which has been reviewed positively and resulted in improved community cover. And we've had positive feedback in regards to improved patient contact, continuity of care, and time to deal with complex safeguarding concerns. With regards to referrals for maternity care, bookings or requests for maternity care have remained stable for the current year. However, there is an increase in booking numbers in March 2022 and in May 2022. Therefore, it's anticipated this will result in a potential peak in birthing activity in October 22 and December 2022. If I can just move on to staffing, and I'd really like to recognise the significant work that's been done by Jane and her team in regards to progress against our vacancies. The current vacancies sit at 25.4 whole-time equivalent band 5 and 6 midwives and 1.1 band 7 midwife. And we will lose a further 6.2 midwives in the coming months. However, through the hard work completed by the division, we've got 23 band 5 midwives coming in September and October via streamlining. We've attracted 6 band 5 midwives external to Wales, and a further 7 band 6 midwives will be starting within the service in the next couple of months. The division have really looked outside of the normal recruitment process and the normal workforce structure to look at what else could be introduced, looking at the prudent approach to midwifery-led services. We've introduced employed as a further scrub nurse. We've got a rolling band 6 midwife post for bank, which attracted 4 midwives with a further 3 at interview stage. We've introduced ward assistants, roster creators, additional healthcare support workers, and for the first time we've actually introduced a band 5 registered general nurse into the midwifery workforce. As mentioned earlier, it is anticipated that maternity service will have by the time we've finished our recruitment, the midwifery service will still have 5.1 midwifery vacancies. Two of these vacancies are band 7s, which the division do not have any concerns in regards to filling. So a significant improvement in regards to the workforce. Additional work and actions have been undertaken by the division, looking at the workforce gaps in midwifery services. Head of Midwifery has reviewed GH midwifery roles and specialist midwife supporting activity. Birth rate plus reviews ongoing. Continue to proactively recruit into all posts and to drive the workforce via the resource bank. Bank nurses and ODPs are utilised to support theatres. We're utilising healthcare support workers from YYF into the community and escalation of community midwives at peak activity. In order to support safe staffing, its process service will utilise maternity leave to backfill and recruit healthcare support workers to support staffing levels. We're exploring the opportunity for a hospital on-call system and exploring the opportunity to undertake prudent recruitment for a potential 10 whole-time equivalent midwives to try and prevent this significant workforce deficit occurring in the future. In regards to sickness is improving, but we do still have concerns around short-term sickness, but it has been managed robustly by the division. As a consequence of reducing activity at YYF, we have seen a significant reduction in our variable pay at YYF, although it's important to acknowledge that our staff out at YYF are still receiving enhanced pay due to the temporary change. So just to explain that, previously they worked nights and weekends. Because it's not the case anymore, but we haven't done a proper consultation, they continue to receive that payment. So in conclusion, the maternity services have been under considerable and sustained staffing challenges, and to support safe staffing and effective care, temporary changes to the midwife-led birthing model was implemented. The temporary arrangement has allowed the service to deploy its workforce to areas with clinical demand and activity, thus ensuring care and service at GH and across the community areas. We continue to recruit proactively. However, we must acknowledge that the new starters starting in September and October will require significant induction and preceptorship, and therefore we potentially will not see the benefits of this new workforce coming into place until December, January this year. As we also know, there's a planned review of midwifery-led service, which is in the process of being commissioned, and therefore giving staffing position and the fact that choice has been maintained for women, the following options for temporary organisation of maternity service are outlined. It should be noted this does not prejudge the outcome of the review, and further consideration of the model of service delivery will need to be considered at the point the review is published. The Health Board recognises that any permanent service change requires engagement with the public, and the organisation is committed to working with CHC on any potential engagement process. So if I can just talk you through quickly the three options that we have considered in the paper. So option one is to extend the current temporary changes to the service model. This option will ensure sufficient staff are available to support GH and community activity, ensure support can be provided to newly qualified registrants and aid recruitment and retention, allow for the expected peaks of activity expected, allow time for an independent review. It will ensure women can attend FMU or have home birth, and most importantly, it will not reduce options for birth for women. Staff will continue to receive 100% enhancements due to the temporary arrangements, but we do acknowledge there will be a requirement to engage key stakeholders in regards to continuation of an extension. Option two, extended temporary changes in a model for services for YYF until January 2023, but open the FMU and RGH and Neville Hall. This option will increase on-call requirements, therefore 5 on-call midwives will cover 4 FMU sites and potentially any escalation to GH. This option will add to the staffing challenges currently being experienced by maternity service and is a potential mother-baby quality and safety risk. Option 3, this option will require an increase in midwifery staffing at YYF. This would be achieved through rotation of staff from GH, thus putting additional pressure on the high acuity area by increasing the use of temporary staffing, resulting in increase in variable pay. Option 1 would currently be the preferred option due to the advantages outlined previously. Additionally, it will provide sustainability of the current services, support preceptorship, improve well-being of existing substantive midwives, support mothers and babies to care for by substantive midwives, and ensure women continue to have a choice of where to give birth. So the board is asked to note the updates in terms of midwifery staffing, note ongoing work in progress to address the significant staffing challenges, and consider options and potentially provide a view on the options provided. Thank you.
Thank you, Linda. That was very helpful, and congratulations to you all and your midwives on maintaining a really safe service in very difficult circumstances, and thank you for all the hard work that the whole division has undertaken in this respect. Are there any questions? Paul?
Certainly support what's being proposed. I just want to understand this table on variable pay, because it goes from 4,000 down to 8,000 over sort of 7 months. Just wonder what, that's on page 5 of 8, or 194,465. Just to understand what that table means.
If I can come in then, if that's okay. So in January, we spent £4,000, just over £4,000 on bank pay to support that service. And as you can see then in February and March, there was an increase in bank pay. So we pay substantive pay to our staff that work there, and where we can't cover shifts, we'll cover that with bank shifts. So following the change in model from May onwards, we've seen a significant decline in the use of bank pay for YYF.
Right, that's helpful, and I think that explains it. Thank you.
Thank you. Pippa.
Yes, just very briefly. I think, you know, I support this, so this is an extension till January, and I'd be keen to make sure that we get some kind of evaluation at that point. And one of the questions I was going to ask you've already answered, which is, you know, whether or not patients are happy with the service that they're receiving, which you've already answered. There's something that wasn't strictly mentioned in this report, but you were talking about patient choice. And out of the review of Ockenden, it mentions that there's a leaflet available for people to give them the choices of where to have their baby. And I just really wanted to make sure that we are not only supplying that information in English, but we're also supplying it in Welsh and in easy read, because when I went to look at the website, for example, I found it quite complex for some people. And I just wanted to check and make sure that we're reaching, you know, giving choice to everybody within our population, not just those who can access that the information that I've seen. It may be there, it's just that I haven't found it. Thanks.
If I can come in, if that's okay. So what we give our women, we direct them to, I don't know if you've looked at the Healthier Together website. Is that the website that you went to look for place of birth? So we direct all our mothers to that website, and they can actually access the information in their language of their choice. Where women don't have access to the internet, then we will give them in a paper-based form. But it's proved really quite successful, the Healthier Together, in increasing our information to the women.
Thank you. I went to cymru.nhs.uk, so I guess it's slightly different information, but that's really good. Thank you very much for that.
Ellen, and then you.
Mine was on a similar line. I think it's just encouraging to see that the patients have accepted this and that no patient safety issues. I suppose when it comes to consultation about future plans, I suppose we have to be honest about what the health board is going to be able to deliver.
Yes.
And not just to be able to say, oh yes, you can have a choice, but in fact we can't actually staff it.
Yeah.
Whereas at least at the moment, they know where they're going to be, and sometimes it's probably more disrupting having a service changed when you're halfway through the process and thinking that's where you're going to have your baby, and then discover it's all been changed. So I suppose it's just getting that balance when it comes to the consultation phase as to what, as we said, what the patients can expect and what is realistic that can actually be provided.
Claire, and then James.
Just around the model, I think you can see the difference in deliveries that we anticipated, particularly at Neville Hall, and that was around consultation with women who said we absolutely want to continue delivering at Neville Hall as we have more deliveries. We want our families to have that, and actually women have voted with their feet in accessing the midwifery unit in GUH, and we've seen that increase. So sometimes what comes out of a consultation isn't what then pans out, and I think that's what we've seen in the numbers. Women want that safety net, if you like, of having an acute unit round the corner, literally in the next room, in the same corridor. So they're going there for safety and security. Those women who choose to birth outside are often second time parents. They've had some normal experience before and they have a bit more confidence. And it's interesting that our home birth requests are fairly constant. And the thing that I hold on to is that those who want home births and can normalise their pregnancy and delivery as much as possible is supported to do so. We also offer choice to the extent that vaginal birth after caesarean section is supported and normalised as much as possible, and we have had requests for home births for vaginal birth after caesarean section, which isn't normally something that we'd be particularly confident about doing in a home environment, but we do consider every woman's request.
Thank you, Claire. James, do you want to add to that?
Yeah, it was really just sort of tying together the points that you know, people state they want one thing in public consultations, but actually that may not be the reality of how people use services. And if we're going to talk about what we can and can't afford to do, I don't think we can afford to deliver services that the population is choosing not to use. as long as we are assured that the population has access to accessible information that allows them to make an informed choice. But at some point, we just have to conclude that the choice that we're being asked to offer is too expensive.
Yeah.
Ewan?
Yeah, and it's kind of followed, sorry, I'm just sound like crack record in terms of the finances. I assume that option one, Rob, is built into the costing. Is it
to our current estimates, yeah, I believe.
Yeah. The one thing I'd request, I guess, on behalf of myself, if anybody else is interested, is having the costs in there. We've been asked to consider 3 options, but we don't have any cost implications of any of them. So, you know, to be honest with you, there are a couple of reports in here today that don't have those costings attached to them. Which makes it quite difficult then to actually almost appraise one against the other.
Okay, so if we can ensure that happens.
Yeah, I just wanted to ask how the staff are coping with these changes, seeing as they highlighted these issues and brought them to the attention of the team leads and everything. So I just wondered how they're coping with this temporary arrangements.
So Linda, myself and Jane may want to come in, met with the Band 7 midwives who'd raised the concerns initially a couple of weeks ago. There was one concern they raised, but Jane's managed to address that already, which was about the increase in telephone calls in particular. But it was really pleasing to hear the staff really reiterate their support really for Jane and the model, but also recognition of the work that was done. And there is further work to do. There often is when you've had a patient safety issue raised, but clearly we're on the right path. Jane, did you want to add anything?
I think I would just add in that the staff at YYF were, you know, they were also concerned about the changes to the model when this was initially brought in. But following on from that, there hasn't been any further concerns. And in fact, they've been quite positive around the changes.
Good, that's good to hear. Jenny?
Chair, just to finalise and confirm, so Leanne and I have agreed to jointly commission the review from an external expert. We've secured a lady from England and she'll be able to complete the review during November. So it's a very short review. It'll be complete by the end of it.
Good. Good, well, yes, I think it's important that we do that swiftly. Okay, so thank you very much for that and for your recommendation that we retain option 1 for the moment. Are we happy to endorse that? And we're keeping a very close eye on the patient safety issues that surround it. And well done for your ability to recruit midwives, because that's not an easy task either. They're a bit scarce, really. So well done for that. Thank you. If we go on to the maternity and neonatal services self-assessment, then we have a break for 10 minutes.
Thank you, Chair. So on the 30th of March 2022, the final report from the Ockenden Review, Maternity Services Act, Shrewsbury and Telford NHS Trust was published. This obviously followed the report from the inquiry published in December 2020, and that set out local actions for learning as well as immediate and essential actions to improve quality, safety and service and user experience. The second and final report obviously identifies several new themes that go not just to maternity, but for wider governance across health boards and NHS trusts and it, but also across wider sharing within across England, NHS England. On the 13th of May 2022, the CNO for Wales wrote to the health boards in Appendix 1 and requested the completion of an internal self-assessment. This is a standardised tool. It had to be returned to Welsh Government on the 27th of May, so that took place. And the tool really extrapolated learning from the Health Inspector at Wales Review of Maternity Services, the Cwmtâth Maternity Report, and the final Ockenden Review. We did return our report on time. However, there was a really short turnaround at that time, and we initially completed a RAG rating that was submitted. We've now completed further work, and we actually have identified further areas which we've moved from green to amber. So we've now increased our amber areas from 4 to 13. That's in the knowledge and further discussion with Claire, Jane and the team around where we feel we are in terms of the assessment. Well, one thing I would say about the assessment is that it is very difficult. The way they've worded the recommendations are really quite difficult in some instances with some of the evidence we have to take ourselves down to amber, but we've taken a really prudent approach to that. So we've taken the self-assessment through the executive team, and obviously, Chair, it's here for the board.
Thank you.
And we're happy as a team to take any questions.
Thank you very much. Are there any questions?
I think it's a very thorough report, actually, and I think the fact that there's so much evidence there as well, which I think is.
Yeah, I think the evidence was really important.
Yeah,
because
very important.
It was a very, very short time scale.
Well done.
Thank you. Thank you. So no further comments, questions? We adopt the report. There's areas to improve and we'd like a report back on those in 6 months, please.
Absolutely. I chair the maternity services and neonatal services improvement board, and we're going to put in place a consolidated improvement plan.
Lovely. Thank you very much.
And just to say that is part of the PQSO committee's.
Good. Fine. Lovely. Okay, we stop. Oh, sorry, Claire.
Sorry, I just wanted to add that just to emphasise really what Jenny said about the questions that were posed within the tool and our other internal quality and patient safety processes. So I would say that the assessment tool itself is by no means exclusive to maternity and neonatal services, and within division, within the maternity assurance and within AB's quality and patient safety agenda are many more areas that are covered. So I wouldn't want the impression to be that the assessment tool covers everything. It absolutely doesn't. So the two areas, the internal QPS agenda that we have that goes all the way through from the centres where we're actually delivering care and the wards all the way through division and up through the organisation are really important as the foundation for the reassurance that we're giving.
Fine. Thank you very much, Claire. That was helpful. 10-minute break, please. Thank you. Thank you. Can I welcome Sam for item number 4.2, the HIW annual report. It's nice to see you again, Sam.
Hi everyone. Thanks, Anne. Yeah, this is. I didn't expect everybody to be in a meeting room. This is a very strange concept for me right now. I was expected to see all your faces dotted around. So yeah, thanks very much. Am I okay to begin?
Indeed, you are.
Okay, excellent. Thanks everyone, and thanks for letting me join you today to present HW's findings from 21-22 inspection year. So hopefully most of you know me as I've done this a few times, but for those of you that don't, my name's Sam Brooks. I'm head of business management, digital and corporate services at HW and the relationship manager for Aneurin Bevan. So if you can move to the next slide, please.
Oh, right. That was a bit of a shock, Sam.
Sorry, I had no idea that made that noise. Sorry, whoa. That's the first time I've heard that. I'm really sorry, because I guess you have to watch it in full slide mode to get that. So sorry about that. Woo.
Well, it's
Okay.
cheered anyway.
Yeah. Wow. Okay, so each year HW publishes an annual report which sets out our key findings from the regulation, inspection and review of healthcare services in Wales. It also reports on how we carried out our functions and the number of inspections undertaken in each type of healthcare setting. So there's an agenda on the screen there for what I'll go through. So talk a bit about us and what we do, our adapted approach throughout last year. I'll give an all Wales summary, so some of the work that we covered across Wales and the findings and themes from that. Then I'll talk a bit more about our work specifically in Aneurin Bevan and the key themes and findings associated with that. And then I'll finish by talking a bit about our future priorities. Okay, so thank you. Next slide, please. Okay, so who are we? So HW is the regulator of independent healthcare and the inspectorate of NHS healthcare in Wales. And our purpose is to check that healthcare services are provided in a way which maximises the health and well-being of people. And what do? We look at the quality and safety and effectiveness of the services being provided to people and communities, drawing attention to good practice where we find it and calling out practice that could cause harm to those who are receiving it. And we aim to provide assurance, promote improvement and influence policy and standards. Next slide, please. Thank you. So our adapted approach, so I'm sure we know it was the same for all services over the last few years, and certainly it was a year of significant change for us, where we adapted to ensure that we continue to check that people in Wales were receiving good quality healthcare. We introduced new ways of working to ensure that we continue to discharge our statutory functions whilst being as flexible and adaptable as possible to ensure we did not add undue burden to a system under already significant pressure. We continued with a full range of assurance and inspection activity, building on our enhanced ways of working to both take action where standards are not met, but also support a broader recovery of health and care services. So to be agile and responsive, we kept our activity under regular review to target our resources most effectively. So how we did this, we continue to discharge our statutory functions. So that includes things like registering independent providers and our second opinion appointed doctor service, which moved to a virtual remote system. We introduced a number of flexible adaptive approaches, and so you'll have seen things like our quality check. We reduced burden to a system under significant pressure, which I just mentioned, and that was by doing things like fewer on-site pieces of work and more remote pieces of work that would potentially be less burdensome for settings and for health boards. We considered the safety of our own staff, so that included things like testing and risk assessments before undertaking inspections. And finally, the rapid development of approaches to look at short and long-term changes in healthcare provision. So that includes things like field hospitals, quality checks, which I've mentioned, but also we would add in pieces of methodology to certain pieces of work where we'd heard about things, changes, increased risk in those areas. So that might be things like adding in records review, for example. So we would deviate a little bit from our standard methodology, if that makes sense. If you can move on, please. Thank you. Okay, so this next slide talks about our numbers. So our on-site inspections and quality checks covered a variety of different types of hospital wards, including emergency departments, maternity, oncology, cardiac, paediatric, step-down facilities, and minor injury units. And so this slide shows HW in numbers. So I'll let you read those on the screen, but you might be interested to know of the 514 concerns that we received. 61 of those were relating to Aneurin Bevan. 20 were categorised as medium and only 2 as high, which compares favourably to other health boards. So yeah, it didn't I guess present us with anything and that we were extra concerned about when comparing to other health boards. And the concerns we received the most for Aneurin Bevan related to clinical assessment, infrastructure, and treatment and procedure. So you can see we got through a lot of work last year across Wales, and specifically within Aneurin Bevan, we did 3 on-site inspections and 9 quality checks, which I'll come on to a bit more at a later slide. Okay, so the All Wales summary. So COVID-19 continued to impact the way in which we inspected and sought assurance of NHS hospitals throughout the year. We resumed all of our routine NHS on-site inspections following the move to alert level 0 in Wales. So during the pandemic, the previous year, we were still conducting on-site activity where the risk met a certain threshold, but we were able to return in full once we moved to alert level 0. And we provided 24 hours notice for inspections to green pathway wards and areas to enable arrangements for our team to be present as safely as possible in an area where the flow of patients is carefully planned. And we continue to conduct unannounced inspections of clinical areas within unscheduled care where the patient flow and conditions seen are already unpredictable. Okay, so these are the themes across Wales. So during our assurance and inspection work, we uncovered key themes within NHS secondary care settings. So there was significant and sustained pressure on emergency care providers due to the volume of patients, which impacted patient care. There's a clear difference between scheduled and unscheduled care, with more areas requiring improvement within unscheduled care. Staff questionnaires indicated low morale, but the positive around that was didn't seem to impact on the experience of patients, who continued to tell us staff were kind and compassionate. Low compliance with mandatory training for staff and medicines management continues to be a concern for us in HRW. Okay, so general practice. So we continue to use quality checks in the main to seek assurance on the quality of care being provided by GP practices during 21-22. And during that period, we conducted 25 checks of GP practice across Wales, which isn't that much when you think of there being 400 to 500 across Wales. And so certainly next year we'll be looking to do more in primary care. So some of the findings from last year. Evidence of practice sharing ideas and good practice. Changes were implemented to ensure environments were safe and could be easily cleaned in response to the challenges of COVID, but also in some places evidence of a lack of cleaning policies and full cleaning schedules, and a lack of completed and up-to-date policies and risk assessments. Dental practices, so we did 76 of those last year, excuse me. I'm not sure if you're all aware, but we have a frequency rule that we apply to dental practices, and so we aim to get to inspect each one every 5 years, which means we have to sort of do up to 100 per year, if possible, and so that can impact on the capacity and resources we have to do other pieces of work. So you can see we did 76, and that's 3 times the amount of GP activity that we did. And that's largely because they pay, and a lot of dental practice, they pay us a fee, and so a lot of dental practices are independent healthcare, and so yeah, the registration and legislation around that determines that. And so due to COVID-19 risk levels, we conducted most of our dental practice work remotely, but we did undertake 9 on-site inspections where the level of patient safety could not be explored remotely. So some positive findings there. So efforts were made to accommodate patients with additional needs. There was good consideration of bilingual requirements and effective COVID-19 procedures in place to reduce the risk. However, some improvements were recommended. The recording and ensuring staff had completed mandatory training, which I touched upon as an all Wales theme across other areas. Lack of up-to-date risk assessments and infection prevention control policies, and not undertaking regular audits to review the quality of care and treatment. So there is a slide missing here, and that's my mistake, that we did have a slide on mental health. So I'll just touch upon that, even though that's there's no slide to accompany it. So apologies for that. So the provision of mental health care during the pandemic has been challenging and complex for both the NHS and independent healthcare services. Excuse me. Screen is just frozen. Can you all still hear me?
Yes, carry on.
Okay, good. Okay. So we continue to use a mix of remote quality checks and on-site inspections for our work to mental health care settings. So this hybrid approach enabled us to seek assurance from services at a time when the risk threshold for conducting inspections was high, and to conduct our work on site when either the COVID-19 risk was lower or whether risk to patient safety was of significant concern. So over the past 12 months, our assurance work evidenced several key themes across a range of settings in relation to mental health care. And so this included mandatory training for staff not being completed, poor medication management, including incomplete administration charts, and medication being stored incorrectly, risks being identified and subsequently not addressed in a timely manner or not addressed at all, care and treatment plans not being monitored and regularly updated, a lack of governance oversight, including collaborative working and sharing information of future improvement. So there's a bit about our mental health work there. So let's move on to Aneurin and Bevan then specifically. So our work to seek assurance to the safety and quality of the care within the health board was a mix of quality checks and on-site inspections, which I mentioned, so 3 on-site and 9 quality checks. We gave consideration to themes and trends presented by concerns and whistleblowing reports. We also monitored data sets and intelligence shared with us. During this period, we have seen evidence of the Health Board working hard through difficult times to recover services following the pandemic. The Health Board has been proactive in sharing the learning from our assurance and inspection work across its services and has also proactively worked to deliver and embed actions for improvement that we have recommended through our work. Next slide, please. So there's a breakdown of the work that we did in 21-22. So as I said, 9 quality checks and 3 on-site inspections. So I'll just let you read those. Moving on. Okay, next slide, please. So there's some key themes that we found across Aneurin Bevan. So as I said, the Health Board has been proactive in sharing the learning from our assurance and inspection work across its services and has also proactively worked to deliver and embed actions for improvement that we have recommended through our work. And the Health Board has kept us up to date on its progress on a regular basis. Now, clearly a challenge for the Health Board throughout this time has been the newly opened Grange Hospital. And we did undertake an on-site inspection to the emergency department and found several issues, some of which required immediate attention to improve patient safety. Staff who responded to our questionnaire told us about feeling pressured and struggling to cope with high levels of demand. But as we all know, high levels of demand for emergency department treatment have been seen across Wales. But I guess this, coupled with a new department, new building and new team, pose an additional challenge for the Health Board. In many of our quality checks, our findings were positive, in particular around access to PPE, with minimal improvements required in any area. However, we were disappointed to note that compliance rates with mandatory training continue to need improvement. So yeah, during this period, we noted the Health Board working hard to maintain service delivery and faces some substantial staffing challenges. And at times, emergency actions have needed to be taken, such as temporarily pausing some services until staffing levels were safe again. And so recruitment drives and promoting positive working cultures across services will need to be areas of focus for the Health Board as it continues to tackle this challenge. The next slide, please. Thanks. And so, so this final slide talks about our future priorities, and 2022 has seen the introduction of our new 3-year strategy. And this year specifically includes a focus on driving and strengthening engagement, improving and modernising our ways of working, and understanding our communities better in relation to equality, diversity, and inclusion. So those 4 bullets there are our 4 strategic priorities, which we're going to be tackling over the next 3 years. And what sits beneath them is a set of key deliverables that we'll be attempting to deliver this year. And to give you an example of some of those, we'll be looking to establish a stakeholder advisory group with diverse and inclusive representation. We'll be conducting a review of our suite of inspection and assurance tools, and we'll be consulting on a new equality, diversity and inclusion strategy. So those are just 3 of the areas we're looking to tackle this year. There are many more which can be found in our operational plan on our website. And so there's just the final slide, I think, just to say thanks for let me come here today to present that. And if there's any questions, I realise you're overrunning, and I actually have a meeting that I need to get to very shortly. So if there is any questions, I'd of course be happy to try to answer them now. But I can always follow them up with an email with anybody if anybody wants to talk about that in more detail.
Thank you, Sam, and thank you for your very helpful report. James?
Yeah. Hi, Dan. My name is James Calvert. I'm the Medical Director. So looking at your sort of future plans for next year, I think they're spot on. I think they reflect concerns that we all have about aspects of our care, and they're definitely a good area to be working on. The comment I just wanted to make was that Improvement Cymru and the IHI are formulating a programme of work for NHS Wales to address quality improvement, and handover and responding to the deteriorating patient are 2 of the areas that they're highlighting. So if you're not already collaborating with them at a national level, it would be very good for you to do so, because the intelligence that you garner when you're doing your inspections will be invaluable in helping to tailor the improvement initiatives.
Absolutely, thanks, James. So we have a partnership function within HRW, and so they'll and also that sits within that team is also our intelligence function, and so they'll be working closely with our partners, and I'm sure Improvement Cymru are one of those. So yeah, thanks for flagging that up. I can certainly speak to the team here, but I'm sure that's on their radar.
Thank you. Paul and then Nicola.
Yeah, I thought it was a very helpful report, Sam. Just one thing for me really is what you do with this report, because what I'm seeing is volume of patients increasing, demand increasing, capacity issues, recruitment issues. Is the message getting through the Welsh Government that this will need additional resources in order to make sure the system is fit for purpose?
Yeah, so again, we work closely with the Welsh Government on our work, but we do have to maintain some independence from them because we can't be seen to be being influenced by ministers or Welsh Government in our work. So we do have to maintain that sort of, I guess, separation. But as I say, we meet with them regularly, and they'll certainly have had sight of the report. But some of those conversations will be happening above my level, and so I'd need to find out a bit more information about what they do with that. But as I say, because we're an independent organisation in that sense, we can't be seen to be being influenced by Welsh Government.
Well, that's probably the most important point. You are independent. It's messages from all the health boards. There's incredible demand.
Absolutely.
From patients, then I think that's a message to the government to say there are some issues that would need to be addressed, and they all ultimately fall down to funding.
Absolutely.
Well, you do joint meetings between yourselves and Welsh Government.
We do.
And Audit Wales to discuss the situation in each health board. So I think your latter message about the pressures on the health board will be really important, that we are coping, but these are our pressures, and you acknowledge that they are.
Absolutely. So just on that point, thanks for that, Anna. I do put a contribution to that meeting, as does each relationship manager, and so that is the most recent meeting that was had. That was the message that I passed up to them. What happens next, I don't know, but certainly that message has been passed from me as relationship manager based on the work that we've done over the past couple of years to reflect that message. So we definitely are doing that, and when I meet with Jenny or with you, Anne and Nicola, I can certainly give you updates on anything that I have from that for you to then share back with the board.
And then Nicola.
Just to add, I came off, didn't I? Sorry. Just to add from my perspective, I'm very used to working very closely with inspectorates, and Sam and I have already had a really good conversation. I think it's not only how we learn from our reports, but how we learn other reports in Wales in particular, how we use that learning to improve and to improve our assurance. I think the other thing for me is around inspection is a key part of our governance and assurance framework, and it's how we build that into our safety and quality improvement for the future. So very, very glad to be working with Sam and look forward to working closely with him moving forward.
Yeah, thanks, Jenny. What I would say about that is, and I think I mentioned it last year, is that Aneurin Bevan is very good at doing that. If you remember, you wrote to us on the maternity inspection, the mass vaccination inspections, about the work you were doing in response to those reviews, and not all health boards do that proactively, and so it was very good to see that. And so yeah, that's something that we certainly feed back to Welsh Government, and when we have those conversations internally about Aneurin Bevan, we and I think it's reflected in this annual report in terms of the sharing of learning and good practice, which we appreciate happens regularly. So that's great.
Nicola?
Yeah, hi Sam, it's Nicola Bogoldic, Chief Exec. We've not actually met, but yeah, thanks for the report. It's really helpful, and we really do value the inspections when you come and really take the immediate assurances seriously and reports. I was just picking up on that shared learning, and I just wanted to draw. I know when you recently visited the ED at the Grange, which is obviously a key area and focus for us, it did get picked up that despite one or two immediate assurances, there were some really positive examples of good practice that
absolutely
was even raised at a NHS Chief Executive meeting last week. I was at from Alan Jones, I think is the name, about sharing the learning of some of the positive initiatives we put in the Grange ED, to other parts of Wales and other ED departments. And in the context of some of the pressures as an organisation we're under around the range, that balanced approach is really important for our staff as well. So notwithstanding the immediate assurance issues, it was really nice to get that feedback from yourselves and to see that shared at a national level. And I just wanted to pick that issue up because it wasn't specifically mentioned, but I just thought it would be useful for the other board members to be aware of that good practice that was drawn out.
Yeah, thanks, Nick, and congratulations on getting the role. And it'd be good to meet in the next few weeks. We wrote to Welsh Government straight after our inspection this year. So this report reflects our inspection last year. So the second inspection, the most recent one, we wrote to Welsh Government directly to say all about the good practice and to encourage them to share that with other health boards, because there was loads of good practice seen, and it was a much improved inspection from the last time around. And we're totally aware that it isn't just the for want of a better word, the fault of the Grange, that we were totally aware that there's system pressures across Wales that are leading to ED departments being under that sort of sustained levels of pressure. There's lots of good stuff coming out of that, and we do make sure we share that with Welsh Government as and when we find it, really, and that was something we particularly wanted to pick out. So yeah, thanks for picking that up.
Thanks, Sam, that's helpful.
Yeah,
thank you.
Just the information of those here, the feedback we got from Health Inspectorate was that it was very crowded, but that it was calm and compassionate and controlled. And it was really incredibly encouraging, because this hadn't happened by accident. The staff had done a huge amount of work to get there, and we all recognise and are not happy with the overcrowding, but the outside look highlighting what we believe we were doing, which was providing calm, compassionate, competent care, came through in the report, and it was really welcome.
Good. Thank you, James. Anything further? No. Thank you very much then, Sam.
Thanks very much. Thanks, everyone. I'm glad I wore a shirt now, looking around at all the suits. I'll be putting my jumper back on shortly. But yeah, okay, have a good rest of the afternoon, and look forward to seeing some of you soon.
See you soon.
Cheers.
Thank you.
Bye.
Bye. Thank you. If we can go to the Regional Partnership Board, there is a report on the last meeting of the Regional Partnership Board in front of you. Just to highlight a couple of things, one of which is this whole discussion about eliminating profit from children's services, particularly social services. There was a very competent and helpful presentation by the directors of social services into this policy and the consequences and their concerns about its implementation in Gwent. There is grave concern about the practicalities of implementing this policy, and real concerns about the ramifications of potentially unregistered placements, which they wish to avoid at all costs. So further work is being undertaken on that, and they will. The Regional Partnership Board will be sending a letter to Welsh Government on this particular policy. And I will circulate that response to you all when I receive it. Well, I think I've got to sign it, so I'll send you all a copy. The other issues about the eliminating profit policy are the implications for other services, like adult services, and certainly the very, very highly specialised mental health services that are commissioned by WISC on our behalf, or indeed by ourselves, and what the alternatives would be if we were not enabled to use people who are providers for profit, and what happens to the profits. And so there are big ramifications for this, which we have to keep our eye on. We agreed the section of the winter plan that is the prerogative of the RPB, which is basically part of this 1,000-bed alternative initiative. We were very lucky as an RPB in that we had not committed all our resource, and therefore it could be funded mostly from that. I don't think other RPBs are quite in that position by the sound of it. So that is being funded from the regional improvement fund, and we will analyse very carefully whether or not those plans are meeting the objectives. But I have to say, this is not the be-all and end-all to solve any of our problems in the winter. It will solve some of it, but the rest of the need we will have to obviously discuss as a health board. On the regional investment fund itself, new rules are now being applied to this consolidated fund. It's brought together two funds that have been running for the past 5 years, and it differs in the respect that after year one there will be tapering, which means that the statutory bodies themselves have to pick up a proportion of the cost of the schemes that are being funded from the RIF. I have insisted that the statutory bodies themselves analyse the consequences of this and sign up or not sign up to the expenditure, because if they're going to have to pick it up, it's part of their budget setting processes and they have to take a risk assessment. So I know it's gone through one local authority so far. We are expecting to make a final decision in December. The RIF has been approved for 1 year only, because we have to have this discussion about whether or not we can continue. And I'm very grateful to Phil for raising the issue of, actually, we're following priorities set 5 years ago. Are they still the right ones for now? And we have commissioned some work from the leadership group to advise us at the next meeting. We are also revising the governance of the Regional Partnership Board so that it is very clear what the roles and responsibilities of the statutory bodies will be, particularly going forward. So hopefully that'll be all right. So there's an awful lot of work going on. At the next meeting, we will be commissioning, we have commissioned a report on domiciliary care and its problems, which is very pertinent to the whole of the issue surrounding health and social care at the moment. We've also commissioned a paper on the use of the not inconsiderable frailty fund, which also comes from the RPB, because I don't think I've ever seen a report on what we've actually spent the money on and whether it's working for the population. So that will be discussed at the next meeting. It's quite an interesting dynamic within the RPB, as so many of the representatives of social care are new, and so there is a sort of a focus now on how we can use that RPB to best effect to meet the objectives that we've set ourselves. So that's what's happening at the RPB. Any questions? Well done, Matt, well done. But anyway, we're getting there slowly, I think. Okay. The winter plan and resilience, we all need a bit of resilience. Chris?
Yes, this builds nicely on what you were just saying in terms of the RPB elements and the regional integrated fund. And what I've just tried to do here is we're trying to set out the process by which we'll develop the totality of that winter plan that we'll need for the next period. And we recognise we've got the usual threats that we try and respond to: respiratory diseases, weather, and the things that we traditionally respond to in winter period. But recognising we also need to factor in the cost of living challenges that we're all aware of and experiencing. And also we now know across a number of industries there are balance for industrial action happening through this next period as well. Some within health and care services, but also the consequential impact of industrial action in other sectors as well. So there is a multitude of threats there that we need to be prepared for. We have been provided only just this week some most likely and reasonable worst case scenario modelling from Welsh Government on what are we likely to expect in terms of a potential wave of COVID, flu and RSV, that's respiratory syncytial virus, so sort of paediatric respiratory disease. I've commissioned some local versions of that and I'll share that around the board so you've got that number of detail. But as a headline, the sort of most likely scenario provided by Welsh Government suggests that across Wales, 14% of the bed base at the peaking period of winter, which is towards the end of December, beginning of January, 14% of the bed base would be occupied by people with respiratory disease. So if you think about it in our context, that's equivalent of sort of 220 beds of the health ward would be occupied by someone with a respiratory condition, or 7 wards, or the medical beds in Neville Hall, if you want to sort of comparison. But I think it's important to hold that figure in mind, because if you look at the next paper on performance and the number of delayed discharges, that figure equates very well with that figure. And you'll see, therefore, in the responses that we're starting to prepare as a health board and as a wider system, a big focus on how we can support people to get out of hospital effectively, how we can drive down those delayed discharges, and how we can support people in the right place. Because in traditional years in responding in winter, we've done it by expanding our staff base to a certain extent in order to respond. But as you'll see in across the pressures that we've got, our ability to expand staffing numbers in the way we might have done in a traditional winter simply aren't there in the same way they were before. So very much the focus of the plan is about how do we support our staff to do the best they can now, how are we enabling them to make the most of the resources that we have in front of us. And therefore a big focus of the actions are about reconfiguration, about working in different ways, and most importantly, what we put at front and centre in this planning approach is a partnership approach, that it is bringing together the actions that we're doing ourselves as a health board, the actions that we're doing through the Regional Partnership Board and the Regional Integrated Fund, and then the wider local authority and social care actions, because it is only through partnership that we're going to be able to unlock some of the challenges. So it gives a flavour of some of the work that's being worked up. And as Anne said as well, what we are looking to do is make sure that we've got really robust measurement. So in each of the schemes and proposed actions, we've asked for indications of what is their likely impact on the system, how can we monitor and know that, and if it's not making the desired impact, how can we adjust that potentially into different areas to make sure that we've got that process. And then the final point I just wanted to make was about escalation, and that is about whole system escalation. So we're having those plans, and we've got a session on the 11th of October with all partners in the room, from social care, from West, from ourselves, to have part of that conversation about if we get to a period where we need to escalate as an organisation, how are we doing that actually as a system, and how are we sharing the challenges across the whole system. So that's the process we're working through at the moment, and then we'll bring back the completed plan over the next month.
Thank you, Chris. Are there any questions and comments?
Just in terms of the projected figures and or at least the projected kind of the feel for the extra intensity, if you like, it is factored into that any increased intensity, if you like, based on the cost of living issues and the fact that more people are going to be cold and hungry and so on. And does that affect frailty, for example? Is it going to impact ultimately on bed occupancy, but also in discharge? So how is it going to affect our flow?
I'll leave Chris to do the question about whether it's been factored into the modelling, but in terms of does it increase the sick people needing care, the answer is yes. So for every degree below 18 degrees that the temperature at home falls, you see an increased rate in cardiovascular disease, so heart attacks and stroke, and in respiratory disease. So that evidence is extremely strong, and it is for every degree below 18 degrees you get an increase. So yes, we will see more disease if people are living in homes below that temperature, particularly if they've got comorbidities.
Because intuitively you'd think that, but that's really helpful to have that.
What about the modelling, Chris?
Yeah, I'm not aware. The modelling is based on scenarios that in terms of flu, is based on what happened in the Australian flu season. So it may or may not factor it in. I'm not sure. And then similarly with the COVID. So it's probably about, as Sarah says, understanding what additionality may come from the cost of living on top of the modelling for the respiratory diseases.
David and then Ewan.
Cool, thanks. So I mean, like Tej, I think I'm particularly concerned about the impact of energy bills and food and other costs and the impact that's likely to have. And there's been a survey today that seems to suggest that many people are already cutting back on heating and food, and that's leading to a big increase in asthma attacks and people who have COPD needing hospitalisation. And that's before we're even starting to hit the real cold part of the year. So I think the modelling around respiratory disease and flu and various other things is all great, but there's another big impact that we're likely to have, and I have a horrible feeling it's likely to be bigger impact in some parts than what we'd expect from a traditional flu COVID year. So I think we need to have a think about how we're going to deal with that and handle that, because I think that's going to be a big impact. We're going to see, particularly in parts of our area, many people just choosing to go without heating or food or both in order to survive, and that's going to lead to a big impact on us.
Yes, I agree.
Yeah, likewise, it's just to follow on from that as to how sensitive our models are and whether or not we've built in, the points that are used and what the baseline is within the family to cope with that. Because if we think it's going to be worse than what our models would normally give us, where are we in terms of what's built into the IMTP then, in terms of the costs we assume that are going to turn up?
What guidance are we receiving from Public Health Wales, who are taking the lead on this?
So they've been involved in developing the modelling. We've had some guidance from Welsh Government in terms of what to plan for this winter. It's mostly focused at the moment on urgent care.
Chairman, may I come in on that one? So in terms of the data, so when we meet with the Community Health Council tomorrow, I'll be sharing data that Public Health Wales put into graphs, which is based on the ONS survey data, which I suspect is, so the 50% are already spending less on food and fuel, and that was in the summer. So I'm sharing that data tomorrow. So we've agreed that, as they did in the pandemic, they need to take the lead on the data and then the developing evidence about what works. And also they are updating their Keep Well in Winter framework that they published in November 2019, and we didn't really get a chance to properly implement. And I had made a note earlier to myself just to chase where they are with that, because we could do with it now, because it is all of the things that people, at least it would give us a framework to assess whether things are likely to be better or worse than normal, because it covers all the things that we're talking about.
I think from lots of the conversations we're having with the acute clinicians at the moment, the modelling doesn't factor into some of those the cost of living sort of issues. So, I think there's further additionality, low level, and lots of the conversations. And when we visited the respiratory ambulatory care unit, Sarah Fairburn, our CD, was flagging, there are people at home with equipment that they need to run on a regular basis, not even just the heating and the heating sort of issues that we've got to consider, particularly they're some of our frailest, most vulnerable patients. So we need to factor in a plus scenario on that, would be my view. I think it's just to reinforce the point that's been made already. We do not have the staff to staff extra capacity. We don't have the staff to staff the capacity we've currently got open at the moment. And I think there's a significant risk for us heading into the winter. We're all very concerned about it, but I think our ability to respond as a whole system and to do things very, very differently will be essential if we are to maintain sort of system safety in the winter. I think, and I know that we've talked about it already, but I think it's really important just to reinforce that our staff are stretched beyond sort of, I think, their limits even now. And our historic response to winter has been to surge capacity. That doesn't exist anymore. And furthermore, it has adverse impacts on our patients that continues this spiral of dependency on our system. So I do think that whole system response is absolutely essential. I think just to reinforce the need for that transformation and whole system response and escalation sort of heading into the winter.
Thank you. Phil?
Just on the whole system stuff, Chris, I think we've got a real fall in terms of whole system modelling, in terms of cost, particularly cost of care, and because of the fundamental differences between the way we work as a health service and local authorities. The care system works in terms of long term. We generally focus on episodes. So the episodes for us are about getting people out of hospital, and we've probably got a 200 bed problem. And I guess what we need to try to do is to model what the cost of those 200 people would be when we move them through the system. Because those costs when you move them through the system would be there for a long time. Because if you look at the national figures in terms of home care, people are now surviving for much longer in a care situation than they used to. So that means the cost is going to be higher. And we don't really seem to have a handle on that. So it isn't just the episode of getting people out, it's where do they go and what's the cost of them moving out. I asked a similar question to the Regional Partnership Board, and it didn't seem to me that anybody had any idea at all of what the cost gap is in dealing with the problem that we have. And that's before we get into the winter surge, isn't it? I mean, we already have a 200 bed problem. That's before we get any kind of respiratory problem or anything else. So I think that's a really urgent piece of work, because until we get that, it will be difficult for the Regional Partnership Board to look at how we reprioritise. Yes. My issue about reprioritising was we may be spending money on things that might be useful and add value, but are not essential in the current climate. But what might be essential in the current climate for society is that we deal with this 200 bed problem, because that isn't a problem for us, it's a problem for society, isn't it? So as we try to explain to our partners, if we can't get people into hospital because we've got 200 people in there who shouldn't be there, that will affect everybody at some stage. So I think that is our most important problem in terms of the whole system. But we're not in a position where we've got a handle on it. What we seem to be doing is following it instead of getting ahead of it. So I think it's a really important piece of work.
So can you take that forward, please, Chris?
So just to answer the question just on the financial plan. So at the moment, following on from Leanne's comments, really, a financial plan and risk range as a potential forecast includes maintaining our beds at the level we are now, which is basically maximised. We haven't currently identified any impact of the plan work specifically against our bed plan, although there are supposed to be swaps. I think in the context of the additional pressure stepping up above where we are now, financially, potentially that's where the winter plan negates that. So we hold our potential financial plan. But what we will need to do is revise and review all of that in light of the more detailed modelling. It's interesting, Phil, your point around the costing of the pathway to like per patient. I think part of the challenge around that is the non-financial data to support that costing and understanding that, because it's, as you appreciate, one individual is different to the norms and understanding those averages moving. But at this current point, the forecast and the risks identified for bed usage.
It's interesting that point about everybody being different, because when we ask the questions about what's the makeup of the 200 people, for example, it's difficult to get any real information other than, well, they're in a delayed transfer position. But really, we ought to be in a position now where we ought to be saying, well, 25% need this, 30% need that, whatever. But it's hard to get that level of granularity about the problem. And that's what I think we need to search for. Until we get that, we don't know the size of the problem, do we? We just know the numbers of people. But, 190 out of that 200 may need very minimal service. But the other side of the coin is 150 might need nursing care.
I think one of the problems with certainly the information we get from the complex care list is that a large number need assessment. So it's really difficult to establish what the unmet need is.
The issue I was going to raise was the assessment. How can we fast track the assessment process? Because that will be really important. I mean, when you're looking at it, if you've got 300 in hospital, shouldn't be there. we've got 200 who we might be having, then, and we've got staff who are on their knees at the moment. You know, I think we've got a duty care over staff as well. So I mean, I think that it's really going to be a huge challenge unless we get some sort of understanding of, as Phil's quite rightly said, what can we do to deal with the problem rather than moan about it.
Yes, I mean, there's something for me around assessment on admission rather than when people are ready to discharge. Because I think there are an awful lot of people who come into our system who would probably know, broadly speaking, what their needs will be, whether they will need continuing nursing care or whether they will need at least a social worker assessment. Some of them will look at and say they won't need it. But and I wonder if we can start to get ahead of requesting the assessments to happen at an earlier stage, rather than waiting until people are medically fit for discharge. And at that point, we start waiting for an assessment. And it's much better for our patients if they are on a continuous conveyor belt, isn't it? And in terms of coming in, getting treated, having their assessment and leaving, rather than coming in, getting treatment, being ready to leave, and then having to wait for something. So I wonder how much of this we can start to get people onto the social services list earlier. And I don't know if it's possible, but
so a lot of that is built into the planning, so things like Home First and enhancing that. How can we get those things up front? So we can provide, I think we are digging more now into the reasons why people are still in our system at a much more granular level, and starting to really using that information to have quite different conversations. And there's also conversations we're having with the public, which Welsh Government are going to help us reinforce about. There is a choice policy at the moment around choice of care home. So that policy is still suspended, but we know on a day-to-day basis for our ward sisters, it's really challenging to have those conversations with families as well. So we're looking to support Welsh Government and messaging around that.
I think for me, there's something just about we want people to be staying at home and being supported in that way. And I kind of feel it's just probably something missing around the when we have people within our hospital system, because our primary focus is to make people medically well, and it's about when we involve other services in somebody's life and have those difficult conversations with families. Is it possible to have them at an earlier point? I guess is the question I'm trying to ask. So thank you.
So we are reassured to know, looking at several of those areas. So first of all, the transformation work we're doing around services for older people. We've identified that if we simply extend the hours of our CRT team, there will be potential that we are able to support 60 more people in their own homes. Because at the moment services shut at 5, which is round about when the peak in referrals is. So, you know, we stop the service at the peak of the curve. So if we extend the service, we'll be able to pick up more of those people. And we know that people who get drawn into the system, we do manage to successfully keep them home. So that's number one. Number two, the Grange was clearly never designed to look after frail people who didn't need complex specialist care. So we're following a two-pronged approach to that. We're looking at whether it's possible to stream using rules that can be applied at a system level through 111, getting people directly to units staffed by frailty and COTI, stop them going to the Grange at all. And then one of the things that was funded with the RPB money this year was a front door frailty service for the Grange, so that when people do get the safety nets and make it there, we pick them up in the ED or MAU and ideally divert them straight out, because what's happening at the moment is people are progressing through into the Grange and then it's 2 or 3 days for their step down, and that's 2 or 3 days during which people are deteriorating, at risk of falls, at risk of infection. So yes.
Thank you.
Paul, can I ask, the co-location of social workers from each of the areas within the hospital?
There was an agreement that we would have a trusted assessor scheme, which meant that it didn't matter where you came from. There would be an assessor wherever you happen to be who would work on behalf. That seems to have gone recently, and Nicola and I were talking about it the other day, and so we are asking the question about why is it gone and why why can't it come back? Because that's saved.
If you had co-location, and I'm taking on what Teacher said earlier, if you've got a co-location of social workers from the particular areas where the people live, they will also be able to signpost any additionality in terms of what's available for help and support with regard to any additional needs. For example, if they come out of hospital, if they know anything in the house, who can they contact with the council, etc. So, I mean, that 200 or 300 or 200 should be able to be broken down into the localities, and then for the social workers to have ownership of those individuals and targeting them, saying, right, this is what we'd like to do. So I'm just wondering whether or not that's something can be factored in there.
That does exist. We go every day. There's how many patients for each local authority is delayed for what reason. I think the quality of the data sometimes is challenged, but we have got a base data. We're trying to improve on that, and that should be then driving our. But a lot of them will be social work assessment, and some are better than others. And we did put the trusted assessor model in during COVID, and we've stopped it. But for me, we are headed into a COVID type scenario potentially, and we need to go into that type of situation in mind. And part of the winter plan for me is about, there's lots of work that we're doing locally in terms of, ambulatory care, cohorting, and we try to capture that and what impact we think it will have. Then what the RPB has agreed as a set of actions for the winter. And the other bit Chris is working with the local authorities on is, what are you doing locally that's within your gift, whether that's improving your recruitment for social workers or your dom care recruitment. What are the, and then do we think that together is going to be enough to see us through? And if not, what are we going to do? So we need to get to that point where we've captured everything so we can measure it. And I think the point that was made around can't keep opening capacity, I think when we come on to some of our later finance sessions or finance performance committee, the work the executive team is just screaming temporary pay. Our temporary pay increases are significant. To the point where, and even when you're on call sometimes and the team just like, get what you can, get some, and that's becoming evident of expenditure. And we know that is not the best quality of care as well, when we are just, and I don't think we can balance the system anymore with a greater proportion of temporary pay to a substantive, because, it is clearly not the right way to do that. And, when we talk about our financial position, temporary pay is absolutely at the top of the list in terms of what's driving a lot of it. At a time when we've lost lots of our COVID funding because we're supposed to be in a more sustainable position going forward. So I think relying on more of that for this winter is not going to cut it. And hence we need to, there's some of the things James described, really trying to guess what impact, estimate what impact we think that'll have. And then when you aggregate them all together, is it enough? And if it's not enough, what's next? Because we can't go into it hoping that it's going to be okay without some of the evidence that sits underneath it that gives us half a chance of thinking this could.
James and Tish.
If you look at the graph from the RPB and look at the major causes of delays, social worker allocation is about 75% of the 75 people of the 373 who are waiting. I've had concern raised with my coaching positions that the average length of time for a social work assessment or a social worker allocation now is 3 weeks. And if the length of stay of a medical patient is pitched to about 5 days, though that's a bed that could be used for 4 other patients in the time when the patient who wants to be at home is simply waiting to see the person who will enable them to get home. So I think working with colleagues on the trusted assessment model is very.
Can I just say on that, James? Takes 75 people. I mean, it just shows how the world has gone bureaucracy mad. When I used to manage home care a long time ago, we used to have patch-based home care managers, long before technology, long before mobile phones, and they used to manage it with 2 sets of cards. The one set of cards would be the clients, the other set would be the carers, and that's the way they deal with it. And they set up home care just like that. There will be no waiting at all. Yet now, because we've bureaucratized the whole thing, it isn't rocket science to organise home care for an older person. It absolutely isn't. But we make it as if it's not like doing brain surgery. We organise some care for an older person. But there's just so much bureaucracy in it. and form filling, all the rest of it. We really need to be bold, and I think just do some re-engineering and say, what do we actually need to do to get Mrs. Jones 2 hours of domiciliary care a day? What do we actually have to do? And if we start to ask those questions, you say, well, we don't need to do that. We don't need to do this. We don't need to do that. My mother was assessed for domiciliary care, I don't know, 2 years, 3 years ago. And she had 4 assessments before she saw a carer. She had a social worker, then she had an OT who said she didn't need any OT. Then she had somebody who came to do a financial assessment who was separate. Then she had somebody who came to do an environment assessment of the home. Now, and that was before she saw a carer. And we wonder where the money's going.
Yeah.
It's just bonkers. I mean, somebody at some stage has got to say it as it is, and it is bonkers. It is absolutely bonkers what we do. I mean, domiciliary care is not that complex to organise. But I don't know why we make it so hard.
You want to add to that, Jennifer?
Just to say that the other issue that nurses have raised to me on more than one occasion is the confidence of the domiciliary and care home sector. So when somebody's admitted, even if they have a care package in place, and that's entirely suitable for discharge, providers are insisting on a reassessment,
yes,
and either face-to-face or via an iPad or an electronic device, and that's introducing more delays. So there is a need to engage with the independent sector as well, I think.
Absolutely.
Yeah, just a slightly different angle. So we've talked about, the process internally and our side of things. We've talked about care side of things, both in terms of social workers, but also domiciliary care in this particular example. But there is another angle and aspect, and that's family and unpaid carers. And there are a proportion of unpaid carers that could help and do want to help, but they feel so left high and dry by the whole system and scared that they're going to be just lumbered with their man or whatever, that they're going to not be able to work, they're not going to be able to undertake other caring responsibilities, that they step back. And I think if we engage earlier, as Pippa said previously, and consistently to support those family members, and I was talking to somebody the other day who is helping out as a neighbour with another member in the community, and she's kind of being dragged into this, supporting this couple, this elderly couple, as if she's a family member. And she just can't afford to do it. She has to take time off work and so on. And I had to say to her, and then look, just stop. You need to make it clear what you can do, what you can't do, and how you can work with the system. So I just encourage us to look at that angle as well.
Yes. Thank you. Thank you. So there's lots to do. It's a very complex, urgent issue. Have a decent plan and action to overcome. So we're discussing it at the planning committee in 3 weeks, aren't we?
I think so, yeah.
So
There's a
we'll
clear
have
timeline.
there's a clear
To pull all these parts together. Yeah. But it's just making sure we've got enough time. If it doesn't go far enough,
Yeah.
we can do different and that change in space and time before.
Okay. Thank you, Chris. The performance overview report of all the front things.
Okay, yeah. So from one issue to the next. So I'll just give a very quick brief overview and some highlights, and then people can ask questions below the conversation. Just partly in terms of process, as you know, I'm trying to change slightly the process around which we bring you these reports, so that on a quarterly basis, we're bringing you a proper more outcomes-based report. We brought you the first one of those in July, about understanding how we're doing as an organisation against the big ticket priorities that we said we wanted to do. And then in this kind of in meetings in between, to bring you a performance report which focuses on the key performance areas against our 5 life course priorities, to try and give you assurance against the progress we're making in the key areas and the performance measures that are there. So this is the first one of those sort of in between the quarterly outcomes reports, really focused on the priority areas. And importantly, I want to say, for example, what I want to as well is push some of the measurement in here as well. So we've got some more quality measures coming through as well. There's a lot in here about the process measures and the performance measures will help against the Welsh Government, but I think we need to bring in more quality measures, and that ties in very much with the priorities that Nicola set out at the start about making sure we've got that focus on quality and safety within everything. So my summary is kind of 3 Ps. The first is pressure, and I think the overall report is reflective of the pressure we're experiencing with the system. Second P is about progress, and there is progress that we're making in particular areas, and there is progress, and some of that progress is simply sustaining our position, which does actually represent progress. And then thirdly, P is plans, and I think hopefully what I'm trying to do with these reports is where we know there is challenge in the performance delivery, that we've got really clear on best plans about how we move forward and take action. So we set it out against the life course areas, and we're trying to bring in more measures around children's activities under that first one as well. So we've got the sort of RTT performance for children there, but we'll try and round that out when we come back to you next time with some rounded measures around children's services. There's some good progress in the CAMS work in the children and young adults work. It's good to see that the assessment known is improving, although still challenges around neurodevelopment assessment, but that's very much a multi-agency responsibility there working in schools. In the sort of working age adults priority, which is where a lot of the measures sit at the moment, there's lots of really good progress that we've made in terms of mental health assessment, but the consequential impact of that is that the work in terms of the treatments is therefore still only making steady progress. But that is a sort of choiceful decision to target the activity at assessments, knowing that we need to understand that backlog and clear that backlog. The report then comes on to the planned care section, and that is where you can clearly see that the challenges that we're facing as an organisation in delivery there. It is worth noting that we are the best performing health board in Wales in terms of our 52-week and 104-week performance. But that's probably not something to celebrate. That's about actually knowing where we are with our peers, but wanting to go much further than that. So really my reflections were, we're starting to see that our outpatient programs really starting to deliver now, and we'll see that, hopefully see that improvement in outpatient performance over the next few months as those programs start to bite. We've got action plans right down at a specialty level now in terms of outpatient work. And I guess then in terms of the long waiting patients, there's a challenge, as you can see, in the long waiters, and particularly those who are waiting 2 years. There's a question for us there, are we treating the right and focused on the right patients? And I do take some reassurance from here that the majority of those long waiters are in the RCS categories 3 and 4, and that doesn't mean those people aren't waiting and not waiting without significant harm and impact on their lives. But are we delivering our activity in our most urgent areas? That the information we've got here shows that we are focusing our activity based on an urgent need of our patients, and in particular areas like cancer as well as in other areas. On the diagnostic side, you can see actually there's some really good progress there, but our performance is mostly challenged around endoscopy, and that relates to the conversation we had earlier around cancer in particular, and the urgent cancers that are coming through that are challenging our position on endoscopy. But we are working on a regional basis around plans for endoscopy because it is a challenge right across the UK really. And then you move into the areas, so cancer, I wasn't going to say too much about because we had a good conversation about it earlier, and you heard about some of the actions that we are taking, particularly in pathology, where we know we need to make those improvements, and the work that we agreed earlier will help us make improvements on that. There's also been lots of really good work done through the Cancer Board under James's leadership and trying to get a really clear action plan for improvements on cancer. So we've been through specialty by specialty, looking at what we need to do and drawing out the key risks. And then finally, we kind of touched on the old challenge around delayed transfer plans in the last conversation about really targeting action in that area. And then I just have one last thing to touch on, which is just one thing which has improved since the report was written. So in the stroke care section, it does mention that we've lost out on some therapy because of the assessment rooms being used for additional bed capacity. That's been resolved. So
at last. Well done, Louis. It's good news to return back to work on.
Yeah. So I'm appreciate there's a lot of information here, and there's probably lots of questions that we're sort of trying to see.
Thank you.
Yeah, thank you very much, and it's a really good report with an awful lot of information in it, which I thought was excellent. Just one question really about, there was a mention of the patients who are electing to wait, as opposed to those who are on the waiting list for a very long time. because they're on the waiting list for a very long time. But certainly we know, and it's mentioned in the report, that there are some patients who are electing to wait. And I just wondered if it would be possible to get those numbers or a percentage of, so that we know how many. I don't want to break it down into our fault or the, do you know what I'm trying to say? Is it us causing the delay, or is it actually that the patient is saying, I'd rather wait for this surgery, but I'll go on the list anyway? If that number came out, I don't know at the moment whether that makes a big difference or no difference at all.
Yeah, we can certainly look at that. And it comes back to the work we're doing with the CHC survey as well, about understanding people's rationale for not coming in or not choosing to.
That's really helpful, but that was the only question I had. Thank you. Thanks.
I think it's a very comprehensive report. Thank you. But you mentioned 3 P's: pressure, progress, and plans. I think you just need another P, pounds. And I think that possibly.
Thank you. Well, obviously, it's a very clear report, and it shows us very clearly the areas we need to focus on whilst maintaining the pressures in other places. So thank you very much for that. The update on the Health Board's local public health team. Can I just say, I look forward to getting the memorandum of agreement with Public Health Wales and what we're going to acquire from them.
Well, if I just talk the board through it, Chair, so the paper is about the transfer of staff who have been part of the Aneurin Bevan Gwent public health team for as long as any of us can remember, and have supported the Health Board through the pandemic response, but are actually employed by Public Health Wales. So this transfer of employment as the Director of Public Health simplifies a very complex employment situation, in that they are they're the Aneurin Bevan Gwent public health team, and they're employed by us. So the paper is for the board's assurance around the financial aspects of the transfer and the QP elements of the transfer. And I'd just like to thank my workforce and finance colleagues for their assistance with the receiver organisation end of this, and also our IT team, who with the staff affected have been really supportive. So the executive team were assured in terms of the nuts and bolts of the transfer, and have responded, the accountable officers responded accordingly. So we're now in the position that we've had a letter from the Chief Executive of Public Health Wales confirming that all is in place and the transfer will happen, and the individual affected staff have also had a letter. So the paper is for assurance around the TUPE element. There's a memorandum of understanding part 1, which is about business continuity for the public health team, continuing to have access to the public health specialist resources that they need to operate. And then there is an intention to have a part 2, which is about how the system works in its 4 parts in terms of Welsh Government, Public Health Wales, health boards and local authorities, particularly the NHS and Welsh Government elements. And the monthly group that the CMO chairs will oversee the development of the text of that, but that will then need to come through board governance, because you are right that it's, although at this point it's the focus is on a safe transfer of staff, actually it is clarity in terms of how the system needs to work, and it has been confused about who is the lead organisation for public health in our area, and I think this removes that confusion, and that does need working through. And there's been a long-standing memorandum of understanding, but the governance around it and the process by which it's negotiated and agreed could be improved.
Yes. Okay. Any questions to Sarah about this? I think it gives us clarity, really.
What's the staff fee of interest?
What's the what?
What's the staff view of that are coming back to join us?
Yeah, so it was interesting because they've been working with us. I mean, they're working alongside, over half the team are already employed by the health board. Was slightly surprised by the initial reaction, and I think it was because they've given us their all during the pandemic, and then for their employing organisation to say now is the right time that we're going to move you. You didn't feel great at the beginning, but we have set, as a health board, we've set out a very clear strategic view around where we want to get to. Glyn came to speak to them, Nicola's been to the induction day. They've been well supported by employee wellbeing in the form of Adrian Neal, who, because they were a team who actually did need their wellbeing addressing after the pandemic. So I think we have made a concerted effort to be very warmly receiving. And so actually now, and the nuts and bolts have gone well. So actually, I think they're in a very positive place. And I have said to the chair, but I do think the chair awarding award to the TPE team was actually at the same time as they were being told this was about to happen. And it was I think it's just all helped with a sense that this board really is serious about population health and really value its specialist public health team.
In fact, it's always been impossible for me to tell who actually employs who in that team because they work together for so long. And
it's just a comment, obviously across the border, public health is seeming declining in importance and significance to the health board. So do you think this is actually going to be a positive thing to bring public health more into the whole of the health board and raise its profile? Or certainly not diminish its profile that seems to be happening elsewhere?
So I would put it slightly differently. I think this health board has had a rising profile of public health over a long period of time. And I think this is about clarity around employment arrangements with the specialist workforce to support that. I think it has been a growing part of the organisation. And again, supported by Glyn and Nicola, the recognition that if we're going to operate on the scale we need to operate on, we need a bigger team than 3 consultants and a very small team. So it has expanded. But there are so in our IMTP we've got what's the legacy around the health protection function, which is one of those things we're still working through. So and Peter and I are grappling with how do we achieve population scale of obesity pathways, which is challenging. So I would say we're still at the beginning of where we need to be, but I think as an organisation across the UK, if you're a public health specialist, there's a lot to offer.
There's someone chalk and cheese here. My interaction with public health as a physician working in the community in England was almost zero. And on the 2 occasions when I did a project with them, it was just of a different order of quality because of their public health experience in interpreting data and then moving that through to policy. So chalk and cheese.
Sorry, and it is translating into recruitment. If I put out a job, we have a strong field, even for fixed-term posts.
And the model in Wales is so much better because in England it's the local authorities that have the control of public health and their funding is reduced significantly. Yes, so therefore the public health part of it has been reducing, whereas I think in Wales the public health and prevention, all the sort of key features which are so important are in a plan that are developed in Wales. So I don't see that significantly.
It's the reason I came to work in Wales. It's the public health aspect of the job description.
Yeah. So I took up post in 2017 and we just had the OECD report, which Andrew Goodall summarised as the model in Wales is right, but we have yet achieved benefits. And because I feel passionate about the model being right here, I've sort of focused on delivering on the benefits, and I think we've done that as a board, and there's no turning back now, is there? But coming back to the paper, this confusion about staff employment has been a barrier to progress, I would say, and this having everybody employed by the one organisation will enable us to make faster progress.
Good. Thank you. Thank you. Okay, finance report.
Let's start with the smile. So the report presents the Health Board financial position for the 5-month period April to August and an annual forecast. The year-to-date revenue position identifies £17.4 million deficit, which is just over £3 million worsening on a worsening trend. So our income assumed includes COVID and exceptional funding coming from Welsh Government as supported by Director General, and that's £103 million. So just to be aware, that's assumed to be received, although we know it is still yet to be confirmed in full. Our pay spend is increasing marginally, but the key point really is our level of pay costs and reducing. So Nicola referred earlier to variable pay, and that's continuing. I'll come on to that in a minute. Similar position for non-pay in terms of overall slightly marginal increase, but we're seeing that consistent spend level and not a reduction there. And in terms of savings, overall achievement remains below plan for the year to date. We've got a lot of schemes which we continue to report and identify as amber currently, but there's a lot of risk with the delivery of those schemes, and we've talked about that a bit later, I'm sure. In terms of the forecast, we've reported a balanced financial position to Welsh Government, and that breaking even is very optimistic from a revenue perspective. Capital, we're more sure of our forecast being achieved in terms of break-even then. The revenue forecast is extremely risky in terms of our achievement of the mitigating actions to achieve that, hence the red rating in the front dashboard. Again, I'm sure we'll be talking about that later. The underlying position is also an area of concern, and given the risks that we are experiencing and identifying to achieve financial balance this year, there's a potential knock-on effect of that in terms of the current and underlying position into next year. And that will be subject to review. As we reported previously, an internal turnaround approach has been implemented, and we are strengthening that, and we describe that a bit more in the paper. And month 6 will be an important month for the Health Board. We'll need to review and appropriately revise our forecast as necessary in terms of reporting the Welsh Government as part of our review process. And whatever forecast we determine is appropriate, we will be held for that until the year end. In terms of specific points to note, I've touched on pay spend continuing at similar levels, and those levels have operated around about 9 months now, so from Q3, tail end of Q3 last financial year through to month 5. Variable pay remains a very significant area of spending for us, and I won't repeat the comment earlier. However, just to recognise that that cost has been driven by our service pressures, responding to COVID, or the implications of COVID, our bed levels over and above our core plan, delayed transfers of care, urgent care, system pressures. We're seeing acuity increase, and that's evidenced through our enhanced care requirements. And in the paper, you'll see that the GUH last month had 35% of patients subject to enhanced care, so it's really significant. And obviously the vacancy cover we have to deal with. However, the most significant drop to note is that there's a level of block beds, and we talked about that previously, so I won't go into that. But it's a significant risk issue for us going forward. We talked about the winter plan, and that's sort of symptomatic of where we find ourselves now. In terms of non-pay, CHC and the support delayed discharges is driving some of the costs there. Medicines remains at a high level,
in terms of expenditure on drugs and prescribing, and an area where potentially take a bit more action. However, most notable is the energy cost increase. So whilst we are assuming a level of funding for that, since July July moving into August, national estimates which we are applying has taken out costs by £17 million as a forecast for the year. So just to note, that is very volatile. There's an always piece of work being done now by our shared services procurement team with England to see if we can get a partnership agreement in place, a joint contract to improve our forecast going forward. Elective and diagnostic activity continues to deliver. And again, we touched on it earlier. In terms of COVID, just to clarify, we're expecting £73 million funding overall for COVID. We've had £11 million confirmed, and we're anticipating 62 million, a large part of which is our local response. In terms of exceptional cost pressures, which the majority of which is energy, we're anticipating 41 million, and currently 33 million is our estimate for energy. We've had similar levels of savings achievement identified for month 6, just over 6 million against our 26 million IMTP target. As I say, we're recording the balance as amber. It's very optimistic, but it's reflective of the mutual point we find ourselves and the opportunity to turn that around, including other opportunities for improving and reducing our risks to the financial balance position. So to conclude, the overall we've got an extremely challenging revenue position. Capital forecast is balanced. Cash target has been achieved for month 5, and the public sector payment policy target has been achieved for month 5. Year to date, I would suggest we're amber, but we're looking for that now to improve given the action we've taken in terms of some of those abilities. Thank you.
Thank you, Rob. A very serious position. Any questions and comments?
I mean, if you look at the reality of all the things we've talked about today, we've got 300 patients who shouldn't be in the place. We've got 200 who may be coming in on top of that. So we've been told by Health Inspector of Wales, which is why I wanted to challenge this in there, that the what has come out of their report is the volume of patients and the demand. So that's evidence-based. We've got the current economic situation and the cost of living and the cost of utilities, and trade unions are balloting on pay. And I know that because I'm involved with the teaching side of things, and particularly union that I'm involved with are looking to 1,000 members on potential action. And I mean, there's just a mixed sort of loads of problems really, and I think none of those are really of our making. So in terms of what we're doing as a board, which is to be efficient and effective, we would be, but the demand is exponential as a result of that. We're having to deal with additional people that we weren't expecting to be there. So I think that in terms of a case to Welsh Government, we think it's important that we just emphasise and evidence. Look, we are doing all we can, but if we got 300, possibly 500 extra patients in the hospital, we either build a new hospital for them, or there's more resources required, or they have to cut things like not having 90 members of the Senate or whatever to sort of help support the NHS and Bevan. I think there's some issues there we need to work on, but I think really what is important is next steps and what is our plan after the IMTP. We've got the plan, but we need an emergency plan really to look at our budget and what exactly we're going to do what we can to sort of reduce our liability or whatever the word is. Equally, I think it's get some intelligence from other health boards to find out what position are they in, because historically, when I looked at all the sort of budgets, we would be nearly there over there. They were way over and got bailed out. We didn't get a gold star for anything. And it's like as if, we do all we can, and there's no recognition of that. What we want to do is, I think, to have a very honest conversation. Say, look, it is a very worrying situation.
So, there's an awful lot of points. In terms of liaising with other health boards and my peers, our cost pressures and the analysis of what they are similar across Wales. So in terms of cost pressures, for various organisations, what that means is a deficit is variable depending on the funding arrangements as you've identified. I think there's an issue for us around what's controllable and what's not controllable by us, and again, you flagged some of those. Our ability to reduce our risk of not achieving financial balance is limited by some of those controllable versus the controllable factors, and I know we'll be talking about that in the committee section. In terms of action, you're right, our IOTP identified our approach to sustainability through transformation, and we've invested in a programme to try and drive that. Headroom and pace has been impacted by all that you've just described, so we do need to do something different now, as you said, and we are, in terms of the executive approach, in terms of looking at what we can do internally before somebody else comes in and tells us what we already know. Well, I think so. That's the unfair part of it. I think everybody's doing their utmost to try and make it work. I have real concerns about staff. Bearing in mind, we got 300 people who are not expected, to be there, that we have to support. And people do a great job there. It's like having a school now with 300 extra people. They're thinking, where's the teachers? Where's the extra support? Where's the extra funding? And that hasn't been provided. So I think there needs to be a conversation on that. Is there anything you feel we can do to help and support you, though? I suppose that's a crucial thing. I think from my perspective, we identified areas of focus, and Nicola led a session last week in terms of us getting a bit more sort of nailed down with our key areas of focus. So there's a challenge for us to reprioritise our work and where we look at in terms of turnaround immediately, if you like, in terms of the short term. There's a discussion around how far that potentially gets us in terms of managing our risks. Ultimately, it may be that we have to consider choices and prioritizations of actual service delivery as opposed to what we can do differently through different ways of working. And that's probably where I think the board needs to think about our choices more broader as we get potentially to that risk position and determine where we go next. But there are steps we can take. That's what we're currently sort of working through. I think not to sort of rehearse the conversation later on, but there's a process described for how we potentially get there. Thank you. Bill?
Bill, we're looking at 17 million gap. Is it at the minute? Is that what we've said the gap is?
Yes.
17 million. The deficit. Yeah. 17 million to me is not a huge amount of money when you look at the money that we spend. It's a small proportion, really. So I think we need to keep it in context. And we've got 5-6 months left of the year to deal with that. Now we could look at that and say, well, we're going to spread that across the organisation. We're going to salami slice it, and each clinical director is going to have a percentage that they have to serve. Just as simple as that. We say the percentage for you is 2% between now and the end of the year. We don't care how you do it, as long as you maintain standards, and that's what you have to do. Now really, that's what management is about. Management isn't really about saying, well, we need to go to Welsh Government for more money. Management is saying, how do we manage what we got to do the job that we've set you to do? Because if we didn't have to do that, it would be very easy to manage, wouldn't it? If it was a bottomless pit, no problem at all. And I would argue, I know this is controversial, but over the last 2 years, there's been an abundance of money. We've got through COVID and it's been very stressful, but it hasn't been stressful in terms of money. Because there's been a Welsh Government money machine that's printed it every week and thrown it at us. And I think, like all public sector organisations, we are suffering because of that, because generally people think that money's going to always be there. So I think we've got a transition now to bring people with us and say, well, that was then, That was in the war. We're in a different kind of war now, and you have to manage with this budget. And by the way, we're going to take 3% off you between now and the end of the year. Well, I don't think that's unreasonable, but other people may think it's unreasonable. But I think that would be a way of redressing the issue that people would start to focus on. We've got to manage the money, and it isn't a bottomless pit. And anybody who thinks that Welsh Government or any other government is going to throw money at health services going forward, I think they're in dreamland. It's just not going to happen. I mean, if you look at what the UK government is doing nationally, reducing taxes, we're not putting more money into it. I mean, the new Prime Minister has taken out the increase in national insurance, for example. That was primarily to give more money to health. So there's not going to be any more money. And I think if there is going to be any more money, the first call is going to be social care now. I think social care has won the argument, supported by health, and I think there's not going to be any more. And we have to make, life's going to be a bit tougher, but that's life.
Yeah, I think the challenge for us is get to that sustainable position.
Absolutely.
Absolutely. He's absolutely spot on. We've had months from last government and more recently as well. So I think we've got to be careful. We've got a job to do for this year. I think we need to be careful how much often as we build into next year in terms of some of our planning and development. That's the challenge for us.
But sending money is not a basket fix, is it? It's a worry, but it's not huge when you look at what we spend, I don't think. It's doable.
You are right in terms of the percentage. That's the way you do it.
Yeah, I mean, if you were saying we're 100 million, then you got a problem. But it's a small amount of money, generally.
It is, and I absolutely accept that. I think the challenge for us is we, as an organisation, we're very hard, run on the margin constantly, and we have for years. The challenge this year is Welsh Government has no slippage in there on the current funding or anything like that, which might have helped us in previous years. And we've got the acuity pressures and everything that's all based all those other operational pressures on us. But there is opportunities for us to do things within our control, and that's what we look at now.
Yeah, I mean, I think we've had the culture of plenty, and now we've got the culture of thrift a bit.
Messaging is a big part. Messaging throughout the organisation, which we started, but not enough will happen.
I think it's an important argument, but we have got to be absolutely assured as a board that we're maximising the use of the money that we're receiving, that we are cost effective.
Yeah, absolutely.
And I don't know that we're entirely on the same page there. But we cannot go into targeted intervention because that will be we will not develop and deliver high quality services if we're going to be constantly under a targeted intervention regime, which is distracting. But the bottom line is we will have to make changes, and we'll have to make choices, and we'll have to be robust and evidenced about the choices and the changes that we make. But I know under Nicola's leadership, she's doing everything with the executives to pull the situation around, given the extraordinary circumstances in which we found ourselves this day. As I said at the beginning, the chairs and the chief executives are going to write to the minister to dispassionately explain what the situation is, largely caused by people having to go into surge capacity already, and we're not even in winter yet. And the pressures that have come through, particularly that of variable pay and prescribing, which is not understandable given the workload that's coming through and the fact that we're having to increase the scope of some of our services, say for cancer, because of the surge in referrals. So we'll have to be totally objective about it. We do not want to overspend. We cannot cut the quality of our services. The scope of those services has increased in terms of volume and complexity. And we are going to have to make choices.
Yeah, very briefly, because I'm conscious of time, we've got a committee session on this, and there's a deeper debate to happen as well. Just, you know, this is a discussion that's being had at a national level with chief executives at the minute, and the challenges being faced around the financial challenge, because we have benefited from non-recurring funding for the last few years. But, you know, the challenges around urgent emergency care and the impact social care challenges are having on us, the expectation for us to recover planned care as quickly as possible, recover cancer in the context of increasing demand, with a workforce that's extremely fragile, not just in terms of the volumes and the recruitment retention issues, but in terms of the headspace to do some of the right things that we need to do. So I think there's a huge concern about how we can deliver all that, and what are the choices we might need to make at a national level instead of us all constantly trying to do everything. So this is the wider context of this, and it's what we need to have a discussion about locally. And what we've been doing as an executive team in the last few weeks is really drilling down to understand the main drivers for that. There are clearly opportunities for us to go at, which is about, you know, making we get the best value for our pound in terms of help us support with the recruitment, for example, to avoid agency, that is not good use of money before we ever into choices. Some of the procurement issues, residence management was a good one. This year to last year, it doesn't seem a huge shift. If you go back to 1920, pre-pandemic, there's a 13 million difference, and we've been managing to cover that through COVID funding, because much of it's driven by pharmacists, prescribing advisors working with the vaccination programme, the market forces factor on the back of Brexit and COVID. And so we carry 13 million of our deficit is just that. They're long-term people. So when you go underneath that, some of these are easier to control than others. And I think, you know, the teams are working hard on how we get theatre efficiency, all of those things, but we need the heads first and the teams with us. So I don't, and the 17 million right now is, you know, potentially focusing up to 50 million by the end of the year. That's what we're talking about. And, you know, we've got a balance around what we think is deliverable in this period of time. You know, so that's the discussion I think we need to have. There is definitely things we can do to improve on that. I've got no doubt about it. And I think some of them are choices about can we continue to do everything, and what's the role of social care in this in terms of helping us manage that particular challenge. So there's a number of factors for us to consider, I think, which I think being a committee session where we've got even further detail that we can have that part of the discussion. But it's a hugely difficult time, I think, for us financially. And just in terms of other pathways, we more or less an outline of the reporting burden ratio. So all the health boards are reporting deficits of different magnitudes. And trying to understand where we are, given we are generally in a burden picture. Are we in stable sectors? Are we in outlier? Where in the areas we might be different to help again inform some of the actions we can take. So we can have further discussions on that. But I think we are in a good position as things. Yes.
Yeah, can I just say that if it's 50 million, that's a different issue, but I'm assuming is the 70 million the worst case scenario? No, that's the point.
70 million is not.
Well, that's the issue. That's it.
Thank you. Can we go to the strategic risk report, please? Yeah. Should I pick this up? Yes. So just briefly, I won't spend too much time on it with the risk report. There's no significant change in the risks that are identified, albeit it does point out in the report that we are going to review all the risks, and there's a number of new risks that will be introduced come up through the People and Culture Committee and the Safeguarding Committee and the Public Nursing Department that we will be factoring in, but we will take that opportunity to do a full review in advance in readiness for the November board. So we're happy to pick up any of the specific questions. Any questions at the moment? No? Take the executive team report. Okay, briefly just capturing a couple of some kind of key headlines and of news stories, a number of staff celebrations, achievements and events that have taken place. And just to add to that, the ED team at the Grange has been nominated for the South Wales Argus Health and Care Award, which is tomorrow night. So quite nice for the team to get some recognition, and that's often some negative press, despite how hard they were working. I think I just wanted to pull out some junior doctors training program again at the ED at the Grange, and also the neonatal unit that have had recognised
recognise kind of that positive, which is really good for the team. And then we just done a bit of a deep dive on mental health and facilities, just pulling out some of the good work. And I will pull out the WCCS did go live in August for mental health services. It was a difficult week for the team, both informatics and mental health, and it was a sterling job. They were determination to get it up and running. A few issues with the software, mainly around pulling the legacy data out. So they were using the system for a while, but we used to use the system for the last period, but you know, it's continuing to settle down and we get these slide on the system, taking away down risk of the previous system. But still lots of work to do around the integration and some of the other benefits which we were able to get to do. But we will be without to W the health code, I'm sure now the most WCCS. Good, because that's one of my objectives.
Right, yeah, I was saying thank you. Oh, congratulations. I was expecting the bunting to be out when I came.
I did say we'd have a big party when we had a bubble. I'll do that. Yeah, okay. Any questions, Sue? You come around that? No? The joint committees overview of activity are here to note. I only have one thing on with, well, two actually. One is at our next meeting, we will have a report on the major trauma. Will they have finished the review of the first year's operations? Yes, it does, but we haven't had the timeline of when that would be. Because we should definitely, yes, see that. So we consider it. Yes, that's it. I'll follow that. Thank you. And I think we need just a note on the recovery strategy and timeline for paediatrics, particularly surgery, which I know caused us concern when we had the last report. So, are there anything on those two? I would be quite interested to give us a bit more clarity around the issues that are linked with our cancer performance. Yes. Because there's a number of specialist services who, you know, likewise will be under significant pressure, as well as imagine there was still some of the specialist gynecology in Cardiff. Yeah. Understanding what their plans are with the have to have a very big impact on our backlog and our performance. Therefore, I'll pick up with them. Thank you. I'll link you involves to you too, but how we raise those issues to us. Thank you. That'd be very helpful. Okay. Then we've got the key matters from the committees of the board. Audit and risk, anything further, Shelley? Charitable funds team? No. Patient quality? No. Comprehensive report, please work. Mental health? No. Shared services? Check to our single report. Okay, fine. Thank you. Is there any other further business for today? I do apologise for this meeting overrunning, but we have got through an awful lot of important work today. And thank you very much for your indulgence. We will start I've got to give you a break. We've got to have a break. We will start in